So welcome everyone to our board meeting, Integrated Care Board, Cornwall and Isles of Scilly. So I'll just say who's not in the room and who might be joining us. So some colleagues are either on the call on Teams or will be arriving late because there is the World Mental Health Day, of course, today, and there is a major event going on in Cornwall, and some of our colleagues, quite rightly, need to be there. Debbie, I know Emma's there, and they'll be taking part in that, and then coming back and joining us. So there's that. Kate has been delayed due to car issues, but Kate will be with us. And I know that Tarn has a personal issue this morning, and she can't make this morning. But apart from that, Caroline, are anybody else that you're aware of who's not attending? No? Okay. So let me do my little introduction and welcome to everyone. Let me just have a look. So I can see on the screen Terry. Welcome, Terry, in your informal capacity today. For those of you who don't know, this is Terry Willows, who from Monday is going to be our company secretary. So looking forward to seeing you on Monday, Terry. So please watch with great interest today, and we can talk more about your thoughts on it next week. I think it would be an important moment, even though Molly's not on the call at the moment, to actually recognise the huge thanks personally and on our behalf for what Molly has done. I think she's had a huge impact on us, and we I can see lots of nodding going on. Wish her well, and I will, with your support, pass on our great thanks to her as a result of that. Absolutely second that, John. Yeah. I think she's done a splendid job for us. So we've really benefited. Thank you so much. So, Caroline, thank you so much for taking the minutes today, and we'll move on. I'm just having a little look. Bear with me. Emma, when does Hugh joining us? Can't hear you, Emma. Oh, still can't hear you. Well, Hugh Savage.
Can you hear me?
I can now. Go for it. Yeah.
Sorry, I was just saying I just sent him a message and I've sent him the link if he didn't have the link, so he should join in a minute.
So I'll just draw your attention to Hugh when he's on the screen. Hugh is the new chair of Cornwall LMC. So there's that. And slight change to some of the agenda today. Caroline, are we still having a brief presentation from some colleagues from Derriford today?
That'll be in this afternoon session.
That's in this afternoon session. Okay, fine. Thank you very much. Okay, so there we are. Well, okay, do grab a drink if you need to, etc. So my introduction, if I may. I just wanted to look back and then spend a bit of time looking forward in terms of where we're going and what we need to cover today. I said to some colleagues earlier this morning, I've never felt more that now is our time. I'm so collectively, wanted to say thank you to all of you, and so proud of the fact that over the last couple of years, I think we've come together as a team, as a unitary board. I think we're able to talk respectfully and honestly to each other in ways that we could never do before. And it's allowing us to actually now have some of the tough conversations that need to be had about system transformation, because it's not easy in any part of the system on your own when some of the solutions are system-wide. And as part of that, in order to facilitate some of those changes, I'm delighted to say that our strategies preceded Lord Darcy, although he has come out with a very similar direction of travel, which I'm happy to sort of say thank you for that, endorsing where we're going, rather cheekily. But with that actually means when we get to the commissioning intentions documentation later on, both in this morning's meeting, which I want to have a good conversation. So I want to try and change some of the timings on the agenda to allow for as much time as we can on those elements where they're going to have quite an impact on what we're going to do, both in year and next year. I also want to sort of say we should celebrate the fact that you've heard me say this before, but the fact that we have had now 3 successive years as a group in the NHS in terms of breaking even, and we're looking to a 4th one And we'll touch on that as we go through. But there are still challenges that we collectively need to work on that are the interests of our 600 or 1,000 citizens. That's about some of our clinically led solutions. And that has to be ingrained in our direction of travel for our commissioning intent. So why am I saying this? Because I'd like us to lay ourselves down the gauntlet of saying, in order to get ahead of the curve for not only making sure that we're delivering in year in terms of money and outcomes, but laying the bedrock for not just 25, 26, but ongoing, that we're able to be in a position where by the time we get to our 12th of December board meeting, that we'll be able to ideally target a level of granularity of detail that everyone is cited on, such that the ICB unitary board can decide its commissioning intentions. So on its journey towards the 12th of December, the paper's being out obviously 7 days beforehand, is the 14th of November's board meeting. So as we go through today, I'd like to ensure, and I'll be a bit more of a pedant than I even am normally in terms of trying to get minutes taken, such that they contain the actions that we as a unitary board want to have minutes today that say this is what this unitary board expect to be led by our chief executive with colleagues to actually come back to this board in November based on not just commissioning intentions, but I want to focus on that, on the commissioning intentions on the 14th of November. So again, papers out a week in advance. So that's first week in November. But we've got really, if you look at it in terms of when the board papers go out for December, we've got 8 weeks, colleagues. 8 weeks to really grasp the opportunity that I think everything now presents us to be able to not only ensure that we're delivering this year, but really being the strategic, shifting the dial, a language that I've used with Kate, I think ever since you and I first met, about how we're going to shift the dial of outcomes, how are we actually going to shift the dial of outcomes in an institutionally agnostic way that is clinically led, that still allows us to actually, Simon, don't worry, still achieve break even for next year as well. So I thought I'd just do that intro because some of the agenda I will encourage you to be swifter on, not because I want to be disrespectful to those elements, but I would like to carve out more time on some of the other elements. So with your support, I'll move on. Is there anything else anyone wants to say at this juncture? Because I'd like to move on. Is that okay? Okay. Now, in terms of declarations of interest, it might be easier if I say for one colleague because she's not in the room, but I assume, Steve, it will go for you and maybe others, but there's a number of items on this agenda that, of course, have a conflict of interest between being a provider chief executive and actually being a statutory board member. So Debbie wanted to have recorded today that she's, when we get to commissioning intentions, is conflicted. But let me just, if you can record that on her behalf, Caroline, I'd be grateful. But I'll just throw it open to everyone because it's not for me to declare your interest, but I wanted to share Debbie's. So, Steve.
Yeah, that's really helpful, John. So I'd also want to restate my existing declaration that clearly I'm Chief Executive for Royal Court Hospitals NHS Trust. As board members know, I'm not here in this board in that capacity. I'm here as a partner member for NHS provider trusts and foundation trusts. And on that basis, it seems appropriate to me that I can take part in the commissioning intention discussions in part one and in part two. Although if any board member suggested otherwise, they'd be very happy to step out of those discussions. It'd be on the basis of me being the NHS Trust and Foundation Trust partner provider member and explicitly not in my capacity as RCHT Chief Executive.
Thank you. And let me just make it really clear. I'm very happy that you stay. It wasn't a request for you to step out. It was just transparency as we go through this process. Carly.
I work across all the organisations, but obviously I'm providing enabling capabilities for the whole system. So
thank you.
Same as Steve.
And
for me to
noted. Anybody else want to add? Now's your moment. No? Thank you so much. Nothing else on generally declarations of interest. So Caroline, we'll note those if we may. So can we move on to the approval of the minutes for 12th of September? Everybody happy to have those minutes approved for accuracy? Yeah. Thank you. So given the fact that Molly was going to be here, but she had a personal issue, because I wanted to be able to say to her, thank you and whatever, she's got a personal issue that's come up, and she was going to lead us on the actions. Is there And with Tracy not being here, are we able to pick up any of the actions, or should we defer that? I'm just conscious we've got a lot of outstanding actions, that's all, which we need clearing. What do you want me to do? Note them?
Yeah, note them and defer them to the
So
next
if you could just
meeting.
make a note to say, can we try and clear as many of the actions for next time? I'd be grateful. And Terry, I'm sure you'll be interested in making a note of that as we go through. Thank you. I see your thumbs up. Okay. So I've just introduced Terry.
Okay.
Health and care vignettes. So I'm going to pass over to Lucy in a second. But Lucy, just before we do, in the window of time we've got for you here, I'm really conscious of the fact there is some absolutely outstanding work that you and colleagues are doing in terms of engagement and that kind of thing. And just because people don't see it doesn't mean it's not happening. So I wanted to give you the opportunity to just explain a little bit about what you're doing. And given that commissioning intentions are on the agenda, the work that you've been doing, I'd like you to help explain how that has been helping inform commissioning intentions and maybe append the work that you've been doing with the team next time round. So over to you for this section, please.
Lovely, thank you, John. So today's vignettes are themed very much around prevention and showcase a lot of collaborative work across the system, both from our public health, our library service, right through to our summer festivals and some of the work that we do with partners to connect with fishermen community as well for the CFIT programme to provide checks over the course of September. We had a big concerted effort. But I wanted to go back to John's point about why we're doing it. And, you know, we are really focused on a strategic approach to engagement. And we spent a long time last year, from May 23 right through to around February this year, going out and speaking, connecting to people across our community. And we made extra efforts working with our partners, working with people who are trusted to speak to sections of the community who perhaps aren't as trusting or able for us to access directly ourselves. And we spoke with over 10,000 people, and very extensive, both quantitative and qualitative data was gathered. And it's all published on our website under our Community Conversations programme. But what really came from that is that our local people have a desire and want to know more about their health, and they want to be enabled and supported to look after their health. They just don't know where to start. Sometimes cost is a barrier. When we spoke to young people, they really wanted to get out and do more, but their income or where they lived restricted that. And the same when we went out and connected with mums and young families, they wanted to do more to look after their own health and the health of their families too. And so what bore from that in community conversation engagement was a desire to work together to deliver a campaign called Healthier Together. And that's what these films showcase. The very start of that happened in July. And what we want to do is really collaborate and showcase what's available for local people to look after their health and well-being. Because we know that if people do get checked, if they go for their cancer screenings, if they go for their blood pressure checks, their NHS health checks, they'll get information about the small changes they can make to make a long-term difference. And we're beginning to really see that happening. And we work with our community health and wellbeing workers. They've supported our campaign. They've been giving out information when they go and visit people's homes. So what we're seeing is what we're asking our local people, we're listening to what they're saying, and we're using that to really make a difference. And it's set out in the commissioning intentions document. That's part of today's board papers. All the findings are out in our joint forward plan and our integrated care strategy to really show that we are listening to what people are saying and we're doing something about it. There are gaps. We do need to do more, and we need to keep going out and connecting with our communities and finding out the challenges, because we know there are health inequalities, and we're devoted to changing that. And these films are a start of that, but look back over nearly 100 films we've brought to board that really showcase the experiences of our local people. Thank you.
Lovely. Yes, Rachel.
Thank you, Lucy. And I think our team have really enjoyed working with you on this, because it has really been a collaboration. And thank you for you and your teams, particularly around the summer wellbeing festivals. But I think it just highlights as well that they're day in, day out. There are a lot of resources and effort, and the public health and Healthy Cornwall, active Cornwall teams are out in communities day in, day out to support health checks, blood pressure, healthy living, etc. But we need to do more of it, and we need to embed it in a whole narrative for the system. So I really welcome what you said. I would recommend that we make sure that we join in the insights from Health Watch and from the Joint Strategic Needs Assessment. So public health bring insights around these areas to that thematic deep dive. So we've got a lot as well around our sort of intelligence and research from the public health side. Just on the blood pressure and the know your numbers, and I raised this at the clinical summit, I think if we absolutely went for this across the system, and I mean in every part of our system around management of hypertension, identification of high blood pressure, we can prevent strokes, we can prevent heart attacks. They are preventable illnesses, so really support that. And we've still got 10,000 people who have high blood pressure who have not been had a blood pressure check and managed within that. So still a bit of a way to go, but a real plug for that approach as a single system of what we could do and make a real difference.
Thank you. Happy with that?
Yeah, I was going to say that that population health data is so important. We were very grand scale when we did our community conversations engagement, but with the summer festivals and our winter wellbeing festivals, we are really focusing using that population health data that's available so we can really target what we do in the places that need us the most.
Very good. Okay. Yes.
I was just going to say that I really enjoyed watching those, and it's all really new to me, and I'm really looking forward to working with you, Lucy, and just trying to extend the scope of that around lived experience for really marginalised groups. So just an example with the factory workers and going into offices, I was like, there's the opportunity to go into places like laundries and factories and non-English speaking and those groups. So that, yeah. Yeah.
Exactly why we wanted you here. Thank you so much, Rich.
Thanks. Yeah, I mean they're great initiatives, and they're great. Watching the films rather than reading about it is fantastic. And I particularly like the plug for involving in research. So that, personally is really good. I suppose I'm just picking up what you're saying, using population data and to look at the needs and where we are. And I suppose I'm a bit, as some people know, fairly data obsessed. And I'm thinking about how we use that to assess the impact and the outcomes in terms of some of the obvious things around, reduced admissions or whatever it might be. Is that happening? Have I missed it somewhere, or is there a plan for that? Or could we look into, as we roll more and more of these out, and as you say, they use resources to do that, it'd be fantastic.
I suggest you do. As you say, you're new to this, rather than take up the time here, could you pick that up with Lucy and Kate afterwards? And if you don't feel you're getting the answer, so come back, but please raise the questions here, and then we know how to point you in the right direction.
I think one of the things, Rich, for next year, we need to be focusing what we do on our segments of the population who need the most help, rather than making a general offer. So I think we should be able to track through what we do in a specified way to the outcome in a specified way. And I think when our place-based plans start coming forward for next year, we will start to see much more specificity around where we're targeting our resources. So it's a good challenge, but it's what we're here for.
Yeah.
So, Chair, as a 48-year-old overweight male on my third cup of coffee and a dad of 5, I'll go and get my blood pressure checked because I fear I may be one of the 10,000. But more importantly, 100 vignettes, how important is that? And all of those messages, all of those people told us about where and how they wanted to deliver their care delivered. So I just hope that feeds in through the strategic commissioning tent that we discuss later. Thank you, Chair.
Okay, and I think that's the point I'm trying to make, which is the work's going on behind the scenes, because it is informing that. But I'll conclude in a second. But Rachel, you want to add something before I try and conclude?
Yeah, no, I think I just wanted to highlight my role as Director of Public Health to be, leading on addressing health inequalities across the whole population. And with Chris and the Chief Medical Officer role, I really would welcome in the commissioning intentions discussion that's done jointly with our work, so that we have a really joined up approach to how because I say the target approach is how we work in public health. And the population health management that we bring to that has got to be part of that commissioning intentions picture as well.
Okay. I think Rachel's points are well made. So Rachel's statutory role as the Director of Public Health holds the conscience of what we should be doing in Cornwall and the Isles of Scilly, because she holds the intelligence around where we should be focusing our attention the most. So that join up between the core ICB team and Rachel's team I think is really important.
Thank you. So now, Lucy, I would normally ask us to sort of spend a bit of time going through these. So I think I've been pretty good over the last couple of years of doing that. I want to make a different point now and then maybe move on. Because the intro to you was about the work that you've done that's been extensive, helping inform commissioning intentions. I think what you and I have spoken about, and with Kate, is that for the November board meeting and for the December board meeting, the focus of the vignettes will move from being here's what we're doing to actually being much more about let's bring our commissioning intentions alive and actually what it might look like with a lens going forward based on the commissioning intention. So I think that would be a really helpful thing to be able to take. If you think about it, the commissioning intentions documentation has got 5 or 6 buckets in it. You do 5 vignettes. If you do 5 in November and 5 in December, I think we'll start to actually see the time we get to December quite how it's manifesting itself from a human, because I think I'm with you, Rich. Seeing it sometimes rather than just reading it helps it bring it alive with pictures and the PowerPoint slides. Yeah.
No, I think it might be really good to test some of our commissioning intentions with the populations that we should be targeting our attention to, and then bringing that back through a vignette. So we haven't rehearsed this. But I think it's quite powerful using the voices of people to augment the intentions that we've got. And I don't know whether Claire would be able to help us with that with Rachel's team. I think that'd be great.
Okay. If you can structure it along the lines of the commissioning intentions paper, I think is that okay? So before we move on, is there anything else that you want to bring out on this? Because you've done some great work, and I don't want to minimise the 5 that you've done, but is there anything you want to pick out on those while you've got the floor?
I think it's just really to say on the Summer Wellbeing Festivals, it was we couldn't have done these events without the help of our local organisations, so the town councils, the Community Hub Network, Volunteer Cornwall, Active Cornwall, Healthy Cornwall. We basically said, will you help us run these events? And they went away and ran with them and organised them. And it would never have been possible for us as a small engagement team to deliver these. So I just really want to say thank you really on record for everyone who's got involved in those. And as you'll see, over 2,000 people attended, 300 checks, and a really good showcase of what's available locally.
Lovely. Thank you very much. So we'll move on, everyone, if that's all right. So we'll move on to my chair's update. I had an excellent conversation with my opposite number from Devon, Kevin, yesterday. Steve, just so you're cited. And at the speed of light, even though I was reporting that we'll get a discussion with UHP and Derriford, that's been fast-tracked. Okay, I believe we're doing that this afternoon.
Yeah.
So thank you for fast-tracking what was in my note. Apart from that, any questions or things anyone wants to raise on my report? Happy to take it. Yeah, done. Thank you very much. Kind of agenda item I like. Chief Executive, over to you.
And again, in the spirit of the report being written and you having a chance to read it, the only thing that I really would like to pick up on is the clinical summit. So thank you to RCHT, CFT and General Practice for releasing people at short notice. It was a pleasure to be there, full of energy, full of ambition for our county, and work that we'll be following up on, and we will be having another one, You Said We Did, Clinical Summit in December. So really great piece of work owned by everybody. So that's the only thing I'd like to especially highlight.
Thank you, Nick.
Yeah, so just really briefly, Kate, that was the part of your report that I was really keen to have a look at as well. So I'm hoping, again, I know I keep going back to it throughout today, I would hope that some of the things that you've mentioned in there, lack of clarity of decision making, speed of access, those types of things, are things that we need to absolutely pick out and thrash out throughout today for setting the intention in November. I'm hoping that's what we're planning to use that information, because it sounds like a fantastic event with lots of people in the room all saying the same thing. Surely it's for us to now try and make those things happen, isn't it?
I think one of the biggest things that came out of it for me is that change isn't a neutral act. So change is actually quite hard to deliver. And what people are asking us for is to be brave. So to stop finding the reasons why we can't do things and be brave around bringing stuff forward. So, and there's a real clinical impetus for that. I left the room feeling really excited. So.
Thank you. And delighted to see that when we get to the BAF and risk appetite statement later on, that sort of match that as well fortuitously. So that's good. Yeah.
I enjoyed the clinical summit too. I thought there was a lot of energy there. I did hear a lot of conversation about permission to spend time as clinical leader, and I think you noted that in your report and how that backfill would happen. So, I mean, I guess, do we feel that that is going to be supported by those of us here, so that those people can do the leadership we're asking them to do? And then I think just on the letter that came out, my team and I read that, and we weren't exactly clear what the clinical reference groups still were. So I think people who are there still need more information about how to engage, because the list of them that currently ought to be wasn't shared. So just thought I'd share that.
So I think one of the things that is becoming clear. So CRG should be bottom-up delivery. So we've got one of the cardiologists at RCHT. Now he knows there's the remotest chance of having a virtual ward for cardiology. He is pursuing it. We've got a vascular surgeon who wants to make sure we don't have people admitted with sepsis, with leg ulcers. So I've just been copied into a conversation where there's 30 people now saying, how do we make sure that that CRG is up and running across the county? And I think it'll be the next clinical summit where the reality of the CRGs comes to light, because I want them to tell us what they've done and what they'd like to do, rather than it being a management description of process. It's a clinical description of passionately driving services. And the point I wanted to make is around time, is where you've got clinical leaders who are determined to change their services. They change their services without having an additional 3 hours a week or an additional week a month. But we also need to make room for that too, so it's both. But I think self-starting clinicians are already up and running and organising themselves on the back of the summit.
I'll bring in Susan in a second, but Steve first.
Yeah, thank you. I just wanted to echo Kate's comments. I think it was a really important event, and it was fantastic to see so many colleagues clinically from across the system. So absolutely echo the comments that Kate has made. And also, we are now already progressing some of the opportunities that fall out from that. Kate shared a very, very helpful summary of 4 or 5 immediate opportunities following that with Debbie and I, and RCHT and CFT colleagues have met and are now progressing some of the opportunities that Kate has talked about. So as well as the kind of questions that Nick was raising about what else needs to happen going forward, that there is a programme of work already now progressing which draws on some of the immediate opportunities from that summit, and hopefully that will help this is what was said, these are the actions that are being taken going forward.
And Susan, as our Chief Operating Officer and one of the key leads on the commissioning intentions, what are your thoughts on this?
So I think the clinical summit has done something that we've really struggled to do, and that's to get the word out and get the word out to the right people to free, or saying in the NHS is liberating the talents, and that's exactly what we're doing. And what that then does is start to generate ideas that sitting in a room with a group of people you may not have thought of. So I think it's fantastic. I think that clinical summit is a start of a series of clinical summits that we need to keep going, that will support the CRGs, Rachel, which will help people understand the role of the CRGs. And in terms of my role as a CNO and a COO, I've always said it's the clinicians that make the decisions, and it's the operators that do the logistics of making sure they move and move quickly.
Feedback that you and Kate gave me is that that meeting that was before the commissioning paper came out has heavily influenced the commissioning intentions paper. So it's built on that Senate, yeah? If we could minute that, I'd be really grateful. Chris?
It's just on the back of, I think, what Steve said as well. So I think to make sure that energy that the clinicians work with the CRGs, and the CRGs are there for clinicians, providers. It's again to emphasise that it's not an ICB. CRGs are for the providers and the clinicians to use. To keep that momentum, I would just want to emphasise that and confirm that all providers are in agreement that there'll be the support for the clinicians to make sure that the ideas that they have to have the channel shift and change will be provided. And I'm thinking in terms of project support, because without that, we know that...
Do you feel you've got that now?
I'd like to just confirm that that's the direction that everyone agrees.
Who are you reaching out to there?
To put it another way, that the clinicians will not feel that if only we had a bit of project support, we could have delivered this by December.
So could we just change that around to say we will make sure we have project support? So between us, we will make sure that our clinicians are supported.
Right.
I think Steve.
Oh, so there you go.
Exactly what Kate has just said, and I think we'll need an element of prioritisation as well. Clearly, we're operating in a very challenged environment from a demand perspective, from a care perspective, from a financial perspective. So I think part of the challenge that Chris is raising is how we ensure that we've got the right alignment so that the programme support, the transformation support resources can be aligned. But we might need a phasing of that, and some of that I'd kind of refer back to Kate's letter, which identified the immediate priorities going forward. They are where the immediate allocation of resources are going. So some of those other aspects might need to be kind of phased as part of our plan over this year and into next year as well.
And we'll come back to that letter as we go through the agenda, because the first 4 of our commissioning intentions are actually this year's actions. So we need to make sure we deliver them so we have a safe and effective winter.
Okay, have to move on? Yes, sorry, Mary.
That's okay. But the being brave point is about all of us being brave, being brave with how we prioritise. Just sort of supporting Steve, you said what I was going to say. The point that I wanted to raise more attention to is the criticality of face-to-face contact between professionals in different sectors and organisations. And I think I wasn't at the summit, but certainly hearing a lot about it, that is really important. And so I think one of the facilities we might need to make available is how do we keep collecting people together, because otherwise they're divided, and yet we see what comes out of a collective view. So are we able to do that, Kate?
So we will be doing the clinical summits quarterly. So part of so the emails I've been copied into post summit, we don't need to do anything. We just need to stand back and let people go, because they are arranging their own meetings. But if we can bring everybody back together on a regular basis, it then becomes a habit. And there was a really big discussion between GPs and consultants how COVID really has stopped them having those face-to-face discussions around individual people, and they want to put that back together again. So our place-based plans for the development of locality services, or services in places where people live, was just, is what people are asking for.
Great, thank you.
Okay, thank you. So just before I finish your report, okay, one of the items you've got there is freedom to speak up.
Yep.
So we're effectively noting the support for the letter that we've got on that. One of the questions, Susan Smitesh, Kate, I wanted to put out there is, it's not just about our 2 big providers, of course. It's heavy, on primary care and that. Are you assured? I'll look to you maybe now. Are you assured that this is actually being embedded, and we have a process that's going to embed this across primary care? Susan?
Well, sorry. So, no, I was just going to say I'm certainly pleased that we're aligning to the freedom to speak up for primary care, and with the introduction of that letter, I can see the start of some assurance for me. It would be difficult to comment on it without seeing it in practice.
Okay, Susan.
So I think we still have a little bit more work to do with primary care in terms of our assurance, because we know that most places follow the national freedom to speak up guidelines. We just need to make sure that that is the case across Cornwall and the Isles of Scilly.
Maybe in your next report, could you just give us your perspective as to its progress in the next couple of reports? It'd be really helpful. Emma, on the screen, and then Neil.
Thanks, John. Just to say, I think I've mentioned this before a couple of times in the meeting, hopefully you can hear me, that the LMC and myself specifically act in the role of Freedom to Speak Up Guardian for general practice. So I'm on their contracting papers. So we do have a process in place, we have a policy in place, and that's been in place since 2018. So that's just to indicate that there are elements that probably need joining up, I think.
So just to link with that, the new bi-monthly quality committee focused on primary care meets at the end of this month, and we've put this item on the agenda, and therefore it would make sense to have attendance from the LMC, which we are discussing at the moment, and exactly that kind of joined up approach can happen at that committee.
Thank you. So we'll take Mary.
And the test of it is, what is the uptake, and how broad is the uptake? And that actually a lot of uptake isn't a bad thing in the initial days, but what's the breadth of the uptake?
Sure.
So Mary just reminded me, actually, so the Freedom to Speak Up app that our CHT have got in place is brilliant, because it means you can raise something without exposing yourself. So we should be making that app available to the whole of primary care, because then it just starts a dialogue. It was really, really helpful in our CHT.
I know you know this, Smitesh, but of course primary care broader than general practice, so I'll be quite interested to see quite how it's picked up in its wider sense. Okay, thank you, Chief Executive Report. So let's go on to committee chairs. So I'm actually going to start with Neil first.
I'm going to ask the board's forbearance for taking a little more time than I might ordinarily have done, taking on board in both my committees that I have the privilege to chair, things that have made me think about what my role is as a non-exec. In terms of the report that you've got on paper for the Quality Committee, that is now being broadened, as I said, to a committee that meets every month now, but every other month with a focus on equity and primary care. The last meeting, which was more the system quality, I need to highlight 3 or 4 things. The end of my comments on system mortality and morbidity group, whilst we are expecting further reporting to the committee in November, I had to say to you that assurance is not given in terms of the quality of care to people affected by fractured neck, femur and stroke. And I think that needed highlighting. Safeguarding, I think the board must be aware of the fact that Safer Cornwall has decided to implement a new process for domestic homicide reviews. This is technically working outside statutory guidance, but anticipates the likely changes that are going to happen in terms of how this process is managed, and therefore the board needs to be aware of that fact. The committee were accepting of that and that it was done with best intentions and in the right way. Quality assurance and accountability framework. This is a really important bit of work that's put all quality aspects on a framework, and Abercrombie is to be congratulated for this in its early iteration stage. The bit that I wanted to share with the board is that a decision was made at committee to share that framework across providers and partners, which opens up the efficiency and the assurance that we are all working in the same way, which at a time of change, with new model of cares emerging, seems a really important thing, that we're getting a framework for quality in place that is shared across the system. The last thing I'd like to raise is the end of life report. The committee received the report and endorsed the taking forward of detailed modelling of option 5 of a report on end of life care. It became clear, receiving the report, that we are not meeting statutory requirements around end of life care. I won't go into the detail about that, but I'd like to say that the endorsement was for a 24-hour telephone advice line with enhanced coordination and rapid community response and virtual hospice. And what the committee really brought to the fore was the need for increased numbers of hands-on care people working in the statutory and voluntary sector in order to keep people at home or closer to home, which means that people should not, at times of end of life, be as often admitted under an acute setting to for them, often an inappropriate setting. So this report was welcomed and will be looked at in detail. I'm going to now take a verbal report with some slides, which is a bit unusual from the ICA committee. I hope you'll forbear with.
Yeah, absolutely, go for it.
In the ICA committee, I don't know if you can put up those slides now. Yeah, in the ICA committee, it became very obvious that, as I've often seen in my time in health and care, nomenclature can get very confusing for everyone. And at a time of change, I thought I'd bring this brief, which I have checked with 1 or 2 key people that I've got it right since the meeting, update from ICA committee. So if we can put the next slide up. Remembering that the ICA committee has a purpose to put people at the centre of any new model of care, and also has a purpose to ensure that care is personalised and integrated to achieve keeping them their care as close to home or at home if possible. So there are a lot of terms that are being used, and a hub comes up a lot. So this, I think, is important. I'm willing to be shot down if anyone disagrees with me in this assessment. Integrated neighbourhood teams are meetings of people, and you alluded to this just earlier, Mary, a collective approach to dealing with very local planning and integrated solutions. It boils down to, I know what you do, and if I've got a problem, I know who to go to. VCSE-led health and care community hubs provide a preventative approach and signposting for people in our communities. and they are very important and need support by the system to maintain their existence and their purpose. Primary care hubs and purpose. There was quite a bit of discussion about this. In primary care networks or across primary care networks, dealing with these allow for dealing with on-the-day issues. I won't use the term minor illness, but on-the-day illness that allows general practices the ability to work proactively in their practices in areas like long-term conditions, end of life, and using AI to identify vulnerable patients who may impact inappropriately in terms of admissions. Sorry, there's 2 more slides, so bear with me. The 3 approaches I've outlined allow better linkage of primary care teams in terms of the establishment, i.e. the above are vital to the success of...
Do you want the second slide? Or you just...
Yeah, sorry, second slide.
Yeah.
Multidisciplinary teams working on proactive and urgent on-the-day issues in terms of long-term conditions, frailty and end-of-life issues affecting people, but working in the community. The development of these teams needs input from partners to underpin the ability of all the above inputs to achieve more to keep people safer close to home, thus relieving pressure on the ED department at RCH Trelisk. Final slide. So we're beginning to look at a minimum of 3 initially, likely in St Austell, Campbell and Redruth and Penzance. I'll come to East Cornwall later. And those do fit with our areas of most inequality of health and would need people resource from RCHT and CFT, especially in terms of frailty and end-of-life care. Settings would include same-day emergency care units. However, the key is and this is the important bit, is a service of people working together in the community. This is joining up primary care and secondary care clinicians working towards, with an MDT, a focus on an individual's problems, which for many people is a number of long-term conditions. University Hospital Plymouth are already outreaching to community services and venues in East Cornwall to achieve this care closer to home intent. So I felt it was vital at this time of change to bring this clarity, I hope it's clarity, to what we mean by the different types of hubs and what they do. Because what some of us thought was not what the place directors were necessarily agreeing on, that they understood by certain things. I'm very happy if anyone's got any contra to that or comments they wish to make, but I thought it was an important update, and thank you for the time.
Okay, thank you. Kate?
So just for our friends in Launceston, because we haven't said their name, I want to be really clear that Launceston are picking up this approach, both in terms of how the general practice is working, wider outreach into the community, and also the liaison services from UHP into Launceston. And Launceston was identified by UHP as a population of great need, that they have deliberately looked at how they'll interface into community services. So I just wanted to make sure that we name-checked them, because again, it's another population of great need for us.
Primary care hubs are emerging right across the county, east to west, in the definition that I've used.
Second, both of those things, actually. I agree with everything that you said, Neil. And yes, the work at UHP hopefully is going to extend a bit further southeast as well, so that we're looking at the East Cornwall part of it. But yeah, they've done some great work there. And just to go back to pick up on something that was in the chair's report around sort of reports around UHP, I think this has been a major contributing factor to how they've worked there, and I think it'd be good to try and look at adopting similar things, as you've mentioned, across the West.
So just before I move on to Steve, I think one of the things which would be helpful, Neil and Smitesh and Kate, if you could just think about it, is part of teasing this out now is we don't need to just celebrate what we're doing now, lovely though that is. But this is all part of getting towards the December board meeting that's about commissioning intentions for next year. It's saying this is what we do now, and here's what we're going to do next year, and articulating what I call the delta, the gap. You need to help explain that. So a little example from me is, I'm not clear, Neil, where mental health fits into this. Lots of general practice understanding. So to me, as we go through the next 8 weeks, I just want everybody to be clear, what are the ingredient elements of a hub, as well as just the badge of it. And I think if we get that definition early, and people agree with it, fantastic. But if not, get it early and then tweak it and change it. So at least we agree pretty soon. I'd like to get to November and there's some understanding as to what the ingredients are. Does that work for you, Smitesh?
Yeah, I just wanted to add to that, actually, Neil, as well. You mentioned in the previous slide around how the hubs are, reducing the input to ED. I think it goes one step further than that. I think it actually reduces footfall to the main hospital sites, and as you said, quite rightly, improves the relationship between primary and secondary care.
Okay, thank you. Steve first, and then Rachel.
Yes, so a couple of things. Firstly, I absolutely welcome the presentation, and the benefits to reducing demand at emergency department I think are significant, and the benefits in terms of long-term ongoing care needs could be equally significant in terms of reducing particularly the potential future demand for domiciliary care, P1 care. So my first comment is absolutely welcome that. The second one is, I suppose, back to the prioritisation point I was raising before, and we're going to have to ensure that we're really aligned on this. There's certainly the frailty capacity is critical to the frailty same-day emergency care units, that the two facilities at Bodmin and West Cornwall that we already have in place, and then the intention to open the third frailty same-day emergency care facility at Camborne Redruth. So I can see there is a potential tension in terms of how we move quickly enough to support the opportunity that Neil's outlined and support those existing transformations and how we move forward. So just ensuring that we're aligned on that would be important. There is a question to me, I guess, and we touched on Launceston, but what this might look like in other areas. So we haven't talked about that model in Bodmin, and where does that sit? Perhaps a wider question from Truro's perspective in terms of where you would need to travel from Truro to access urgent treatment centre minor injury unit, hub support and other aspects, and there'll be other communities that we could raise as well. And just a final comment, I think the challenge on language is really helpful. And I was sat here listening to Neil thinking about channel shift. And one of the challenges I've experienced from colleagues across the system, never mind patients and communities, is what on earth do we mean by channel shift? So perhaps that's a question to kind of take into a further discussion, whether there's a better description that would resonate with clinical colleagues, patients and communities about what we mean by that. Okay. In no way distracting from the strategic intention for channel shift, but it's just really how we...
Thank you. So I meant to say to you earlier on today, rather than let's just go from colleague to colleague to colleague and make an observation. So I think we ought to conclude some of these. So I want to, can we just take the slide down off the screen for a moment for colleagues who are on the screen? So Steve, I want just, before we move on that one, there's an example for me where quite rightly what you've raised is whatever we're doing today, Launceston or whatever, when we get to commissioning intentions, we need to be clear on what we're saying come December. What does this mean for Truro, Redruth, Camborne, other places? We might do something different in Redruth, probably, to what we're going to do in Padstow and that kind of thing. So for me, it doesn't have to be everything, but what are we actually saying we're going to do, where, by the time we get to December, that we all go, do you know what, I understand the implications of resources, finance, money, working or whatever, that we all work through the wrinkles between now and December to be clear on where we can alight then. Is that a fair challenge?
That would be really helpful.
Yeah, really helpful. Cool. So we're going to go Rachel and then Mary.
Very quick point. One, the language about hubs made me think, would it be helpful to have reference to some of the other hubs that are non-NHS hubs that I'm aware of in the community as part of the conversation? So the council, support safe and well hubs, the people hub, there's a couple of other things. Where should that information go? And then the second thing I think was gone out of my head.
Come back. Let's get an answer from Katie on your first one, Rachel.
So I think we should be asking our place directors to do the translation of what they've got in their places and how it comes together in terms of local access to services. So our nomenclature in many respects is irrelevant. It's what people understand in the places that they live. So I think we should take that back to our place directors and ask them to tell us how they're managing their places.
Just my second thing was an offer, which was we have a system, a mapping system, which is public sector infrastructure mapping, and that can display on a map where physical places are. And I wonder if you wanted to take that forward, we could ask our teams to have
Very
it
good.
visually for part of your planning, because I think that usually helps people to.
People are very happy with that. So again, just before we move on, how do we not end up with a postcode lottery of if place directors want to do one thing in Launceston and something in Truro? At what point is our commissioning intentions going to say, here's the core and here's the local? How are we going to be not quite so devolved that we end up with a postcode lottery?
For us as a population health planner for strategic service delivery, we will end up with some facilities in one area that aren't in another, because we're targeting our money at the places that gain the greatest benefit. So the reason why the population centres of Penzance, Camborne and Redruth and Bodmin and St Austell have been identified is they are sort of like our epicentres of need.
So those are the places we're going to start.
Absolutely.
And that's what needs to come back and us all agree. I'm going to be a bit of a pedant today. That's what we've got to agree. Mary.
Just today, John. Teasing you. Just 2 points. I really welcome that, and thank you for making that a brief presentation. And I want to put this completely respectfully, because I'm sure you're touching on it. But in talking about all the multidisciplinary teams and how we bring people together, which is fantastic, how are we and where are we including the family and the neighbours, so that we're making sure that family or neighbour care and implementation of, so we don't do it all ourselves, because I just worry as to how we are making sure that we are including families.
Thanks, Marie.
Okay.
Certainly, one of the place directors who you know well, Juliet, was here. In all the discussions we have, she brings us back to personalised care and what's right for patients and families, and not losing sight of the person who you're dealing with, which is why there was an effort to describe integrated neighbourhood teams as not being necessarily around a person-centred approach, but the person-centred approach being facilitated by people talking to each other about what's best in terms of looking after people. And that's where the end-of-life care paper comes in. Right thing for people and listen to people. So they are part of any discussion, and that needs to spread across as a cultural shift in terms of how multidisciplinary teams look at people's needs.
Very good. Okay, so we're going to go Martin, Hugh, Steve.
I think I'm slightly backing up your point and Kate's, actually. Your point about resources, money, etc. I was thinking we're going to set something up. We need to make sure it's resilient and robust and operating to the time we want it to operate, and not just on a wing and a prayer and sort of grace and favour basis. And I think that comes back probably to Kate's point about prioritising. You know, let's set up 3 things that work really well and are properly set up, rather than do 15 that don't really work. Would be my advice and my plea, please.
And the other element that goes with that, Martin, I know we've spoken about it, and Smitesh, you and I have had the conversation too for your seat that you're here for. There's something also about understanding what the outcomes and outputs that we actually have, because if there's certain things that are done at place and general practice and primary care level, it will have a positive impact on A&E and UEC and Trillisk and that kind of thing. And rather than just say, here's the shift, what's the benefit of the shift? Not just in broad language, but something that is measurable, can be tracked and scrutinised, and we gain assurance on. We do need that level of, if we're going to move X to Y, what's the benefit of doing that? And it needs to be numerically measurable. So then we go from that. Sorry, I've already forgotten. It was Steve next, I think. No, it's Hugh. Hugh, I apologise, Hugh. I knew. Welcome, Hugh, for the first time, by the way, the chair of LMC.
That's right. Thank you very much. I think Neil, I welcome your report pretty well. The definitions of the hubs, I think, are clear, and a bit like having a clear definition of channel shifter is really helpful. Having a clear definition of what the hubs are is helpful. So thank you for that. Where do you put them? That's really difficult, and I think that requires good leadership, because I think you're always going to upset some people about where you put them, and I think actually it's leadership that assesses the area, assesses the data, and decides where these go that is probably the right answer. But I also urge a bit of caution. The more hubs we have, the more we fragment care, the more we take continuity of care away from GPs, which we know works well. That is the direction of travel. That is what the Darcy report is saying. That's what Claire Fuller is saying. She is trying to produce these bigger hubs, more PCN-based care, but that is fragmenting care, and we just need to be very careful that we try and find a way to maintain that continuity whilst also bringing that in. Equally, the other thing that goes with it is this is the opportunity where you can get the secondary care colleagues to talk face to face and get to know the primary care colleagues again, which can then lead to better conversations and better outcomes. So there's lots to like, but there's lots to be cautious about in continuity of care.
Thank you. And here, as we spoke about yesterday in our conversation, there's something about using the next 8 weeks just to be clear on where, to what degree. And Kate was just saying to me privately there's something about understanding, Kelvin, the digital issues that are embedded in these solutions. Steve?
That was just a really brief comment. I think it applies to the summary that Neil gave, but applies to all of our other transformations. The clearer and the more simple and straightforward they are, the better. Just thinking about the thousands of healthcare practitioners we have across the system who will be signposting or kind of redirecting colleagues and patients, not just to the hubs, but to our frailty services and elsewhere. So being able to convey across our whole system with clarity and would be an important part of enabling the success that Neil's outlined.
Okay, thank you. So, Neil, that was a really important contribution. Thank you. And I hope you were all okay with letting that run on a bit because it's taken up a large part of time. But how important was that? So thank you, Neil, for helping us get there.
Apologise to Hugh because the word allowing better continuity of care was meant to be in my talk, but I...
No, don't worry. Okay. So bearing in mind that's the first committee chair update, I'm going to push other committee chairs to be... So I'm going to go to Sanj first. Sanj, oh, he's not here. Right, over to the next person. But we'll come back to maybe his in a moment because he was meant to be here, so I don't know where Sanj is. Martin?
Nothing to add to the written report.
Thank you. Nick?
No report this time.
Thank you very much. And Tan, who's away at the moment, so that's great. So I'm going to turn first of all to Smitesh, because again, Smitesh, there's something here about your seat. You've been with us only a few meetings now. There's something here about your scope. I know you've been working with other partners in your space. What would you like to add and really bring out, not just for now, but what we might see in November from your seat?
So I think, thank you, Chair. I think what I've written in my paper, I will take it as read, but I just wanted to highlight a couple of things in terms of initiatives that are going on with the help of the primary care team. Obviously, patient risk stratification is a really important one and goes almost hand in hand with the work that we're doing with hubs. And I guess just alluding back to that continuity of care piece, the patient stratification tool that we're trying to implement throughout the county will help us identify those patients that do require continuity of care and those that we can perhaps send to a hub. So if I put it in a really simplistic, because I'm quite simple, it needs to be fairly simple for me. So if I put it in a really simplistic fashion, if you stratify those patients as sort of green, amber and red, if you like, green being those patients who are more sort of same day type care and just maybe sort of minor ailment type issues, those are the kind of patients that can easily be stratified and sent to a primary care hub of sorts. Okay, and the red patients are probably those patients that all primary healthcare practitioners are in contact with on a regular basis and are probably more aware of. But that key group in the middle, that amber group, are the one where they may start to cause an issue, they may require some proactive intervention. So I think that piece of work is really important to tie everything in terms of the kind of commissioning intentions we're talking about. Along with that, I've alluded to personalised care support plans, which is another initiative we're trying to standardise across primary care. Once again, I guess identifying those red and amber patients, but also those patients perhaps coming towards the end of life, who, as Neil alluded to, we don't want them unnecessarily attending into an acute hospital setting, and making sure that patients' wishes have been thought about and planned in advance, but also more importantly that every healthcare practitioner and every practitioner within the VCSE, for example, has access to those personalised care support plans and is aware of what those patients' wishes are and what those families' wishes are. So I think those two things were really important to add to that and need to be tied into those sort of commissioning intentions. Second thing I wanted to talk about was Dr. Claire Fuller's visit, really inspiring visit that we had last month. Some of my primary care colleagues from general practice and pharmacy were there, and she sort of highlighted the priorities, I guess, for primary care from NHSE, which I'm sure you'll all be aware of, but three of the most important ones: GP retention, patient safety, obviously, and for me, I guess one of the most important ones is improving the primary and secondary care interface. I think it's through that we're only really going to achieve what we need to make this work. She also mentioned that Cornwall is probably an area that would benefit from multiple neighbourhood care centres. I don't think this is unique to Cornwall, but the interoperability between primary and secondary care is not the best. I think that's probably throughout the country, and speaking to colleagues, across the nation, that can be the case. And I think, again, hubs and some of the things that we've talked about in terms of moving from analogue to digital services are going to be able to help that. And one of the things that she also highlighted was around our sort of data quality. We gather lots and lots of data within the NHS, but the quality, the quantity is there, but the quality isn't necessarily there. And trying to improve training to facilitate better interpretation and better quality of data. She talked about Brave AI, which is one of the patient stratification tools that we can use, and again, that will address some of the things that we've spoken about already today around sort of high ED attendance. But as I said, taking it one step further and trying to improve kind of proactive care in the community as well, and using things like Brave AI to do that. At the moment, there are some really good examples of PCNs across the county using their R's workforce and integrating with community teams and those from the voluntary and care sector to enable this to happen. Obviously, she alluded to the Darcy report, and I'm sure we're all familiar with it now. I did include a little summary there, but some of the things that I think I found reassuring, certainly today, and in some of the papers that have been expressed, re-engaging staff, but particularly re-empowering patients. The great health and care vignettes that Lucy's been bringing, and the discussion we've had around that, re-empowering patients is one of the huge things that will help us, shift the NHS up. I probably call it asking patients to take a bit more responsibility for their own health, as I've seen a massive downturn in that during my time in healthcare. And I think it's really encouraging that on a national level that's been recognised, and we're already bringing it to us at a local level. Locking in the shift of care closer to home, I think we'll probably talk more about that in our commissioning intentions discussion, but I think it's really key and also reassuring that we're already looking at that kind of thing in Cornwall. Mention sort of driving productivity in hospitals. I know that's always, it can be a bit of a boon to talk about, but I think we'll be discussing that in some of the papers later today. And tilting towards technology as well is a really important factor that I think we're really starting to use in primary care, particularly with the use of patient segmentation and Brave AI. So I think, for me, putting all of those things together, I think there's a really investable product there in primary care, which will, mesh quite nicely with all of the other sectors that it needs to bring everything up. So I hope that was helpful.
Very helpful, and that's an excellent update. And when we get to the commissioning intentions bit, particularly yourself, but also Hugh and Emma, I know you've done a lot of preparation work on commissioning intentions too on our journey, but please make sure you bring that out as the day goes on. Okay, thank you. Let's move on. So, Ali, would you like read your paper? Lots going on there. What would you like to tease out for us, please?
So the paper that you've got this month, colleagues, is a edited version of the Cabinet Q1 performance report for the council, so it's quite broad. I wanted to make an apology because I'm not very good at coordinating this month's report with any input from the ICB, so I do absolutely need to strengthen that, and I recognise that. Listening to the conversation this morning, though, Chair, I'm thinking next month I'm going to bring a strong focus on the transformation of care, and I'll focus on personalisation, bespoke packages of care, prevention, and a whole range of stuff that's happening, particularly in social care, just so I can share with colleagues and we can drive out those opportunities to collaborate more as well. So I'll just take any questions, really.
Thank you. Any questions for Ali? Lovely, thank you. I'm going to move to Debbie next. Thank you, Debbie. Now, another excellent report here, which I'd like you to give you the chance to say what you need to say about your report as well.
Thank you, John, and thank you to colleagues, because today is World Mental Health Day.
Yep.
And the reason why I was late was because I had the privilege of opening the Cornwall and Isles of Scilly World Mental Health Day event at the Weybridge Showground, and I was absolutely blown away. There were hundreds of people there. Service users, voluntary sector organisations, statutory sector. There was incredible representation. It had been co-designed as an event with service users and volunteers. So there was wellbeing yoga. The Eden Project was there, helping people with planting projects, but also there was like a market stall place so people could get advice from a whole range of organisations and engage with one another. So it was really inspiring, and I promised everyone in the room that I would actually bring them to this meeting today and just take a moment to ask us all to reflect on the importance of really good mental health and well-being. And the theme this year for World Mental Health Day is mental health and work. And actually that resonates with most of us, and it certainly resonates with the government priorities as well. And it was great to see our Pentreath colleagues there who lead our IPS, which is our IPS service to bring service users into work. So that was absolutely fantastic. But we also spoke about the importance that we all have as individuals to promote good mental health, but also to reach out to one another. And it's a time to reach out to one another in the workplace, as well as to people who use services. And it's a time for us all to try and remove stigma and encourage all employers to consider how they can make reasonable adjustments and better support people with mental ill health or a learning disability into work. So thank you for indulging me, Chair, there. I would like to also highlight my report because although I came in late, I heard from Neil and then from Smitesh, who haven't yet met. And I think this report, although it wasn't coordinated to be such, actually follows that theme of this is what we are doing together in an integrated way, actually to improve care to patients, but also how we're working in a more novel way. And whilst this was part of the national community mental health transformation drive, you can see that the partnership that is evident now across all of our PCNs is writ large in this report. And the authors of it are Dr. Jeremy Sandbrook, who some of you know from CFT. He's been our lead for that, but also Stuart Smith and Mark Morris are phenomenally helpful and supportive allies in primary care, and they've really led the way with this. And so this isn't CFT transforming itself, this is CFT working together with each of the primary care networks, but also the VCSE to embrace the true principles of transforming community mental health services in full recognition that the majority of mental illness is seen and treated in primary care. And so for me, this is a really important demonstration of channel shift in reality and how we have recruited the unfortunately named R's workers, but the paper gives that detail, but also that maturity to the board, so they've got oversight of it. So my one ask is that, well, it's really two asks, Chair. One is that we provide support as an ICB to all PCNs so that they all raise up to that level of maturity. You will see in our IPR that whilst we are meeting the activity for 2+ contacts, And that doesn't count the R's activity, by the way. We can only report on 3,500 of that because you have to report it from a transformed PCN. So it does impact on our performance as well. But also, this is something that I want to come back to in commissioning intentions, because I would really like to see things like this writ large in commissioning intentions. Thank you, Chair.
Anything else? No? Okay, happy to move on.
Could I just pick up a couple of things that Debbie's made, a point she's made? So it's World Mental Health Day today, but it sits in Black History Month, doesn't it? And we know that in terms of access to services, often for people who've got severe and enduring mental illness, that if you are non-white, your treatment outcomes aren't as great as they would be if you were white. And that goes across a whole load of other physical health services as well. It was raised at the Clinical Summit by one of our colleagues who feels we need to have a much greater grip on our ED&I inputs and outputs, so that we use evidence to develop our services. And I think it's great that we've got the Work Well initiative in Cornwall, because aligning that with getting people back to work who have got who have suffered from mental illness either episodically or for all of their lives, there needs to be a link up between that, because we know working makes you better. So great opportunity for us to tie some of our things together.
Thank you.
Thank you for the report and the focus on mental health awarenesses. And I was just picking up around, obviously, the mental health and the physical health of people, because we know that often people with a severe mental illness die 20 years on average earlier than the rest of the population. So just looking, and we're going on to the performance report in a bit, around the physical health checks. It's always been a bit of a challenge for Cornwall to get our coverage and make sure that the physical health checks of those clients are completed. We're still quite a long way under what we'd like to be, but I can see it's going in the right direction. I just wanted to draw attention to that, because whilst we're thinking integrated, we don't do one thing or the other, and there's these mental health and wellbeing coaches and other sort of primary care R's roles, just to bring that to the table and say, what are they doing around those physical risk factors that they may be able to intervene?
Okay, thank you. So let's go on to our next partner member, which is Steve.
Yeah, thank you. So mindful of time, I'll just cover a couple of things briefly, if that's okay, John. I want to start by recognising the opening of the St Austell Surgical Elective Hub as planned on Monday this week. So a huge amount of work from CFT colleagues, from RCHT colleagues, from ICB colleagues working collectively, and fantastic to see that opening on plan as expected on Monday this week, and to see our first patients receiving their surgery on Monday. Really, really positive. And I want to express my thanks to everybody who was involved in enabling that to happen. We have experienced an estates issue yesterday, which has impacted operating yesterday and today. And I just want to take the opportunity to update board colleagues around that. So we are still working through the details, but it looks like there was a power surge which has tripped and impacted the power boards at St Austell Elective Surgical Hub, which has impacted operating yesterday and today. We're currently hoping that will be back up and running as soon as tomorrow, although I can't confirm that at this stage. So RCHT and CFT colleagues have been working extremely hard to address that issue and bring that service back online. Notwithstanding that, really, really positive, and a huge amount of work from colleagues to enable the opening of that facility. And I'm sure it will be back operational over the course of either tomorrow or into early next week. That's the first thing I was going to mention. The second thing is just to recognise the ongoing work across the system to improve our waiting times. And really positively, our ICB now has the best position in the Southwest region for the smallest number of people waiting more than 65 weeks and the smallest number of people waiting 52 weeks. The best performance for under 18-week performance across the Southwest region. Clearly, we've got more to do. We all know that, but really positive to see the actions of colleagues across the system impacting and starting to make significant inroads in reducing the waiting times for people waiting for their outpatient or for their elective surgeries. Just looking ahead, I've already mentioned that we've got our first two frailty SDEC services operational, and we expect to open the third frailty SDEC service at Bodmin next month. So a further step on that journey to provide more care close to home. Neil mentioned two of the key quality and outcome risks, fractured NOF and stroke, and you'll see in the report there is some detail about those areas. So positive to see improvements in the time to fractured NOF surgery within 36 hours, which is important, but still more to do. You will see in stroke that one of the key challenges is time to access to a specialist stroke ward, and that is significantly below the performance that is necessary to support the stroke outcomes that Neil touched on. That is predominantly impacted by the urgent and emergency care pressures which are being experienced across the system. And one part of that is the flow out of RCHT and the flow out of CFT. And colleagues are aware of the challenges and some of the deterioration we've seen in terms of no criteria to reside patients within CFT and within RCHT. But you'll also see in the board report that the UHP position has deteriorated recently from a no criteria to reside perspective. So pretty much all parts of the NHS provider system are under pressure, and all of the things we talked about earlier on in this meeting will be important and instrumental to enabling those aspects to be addressed. And the final comment I think I'd want to make is all providers are continuing to take a range of additional escalation and extraordinary financial management actions to continue to enable UHP, SWAST, RCHT and CFT to return where they need to an in-budget position. And I think I just want to point to some of the significant success that CFT have seen in terms of controlling and managing overall workforce and in some of the temporary aspects of that. So that's one example of the sets of actions that are underway across all providers to manage within the financial environment that we're in. Happy to take any questions on any of that or the rest of the report.
Okay. Thank you.
I think we should note that the elective surgical hub's opened, and great piece of partnership work between all people in Cornwall and the Isles of Scilly. And I just would like to say that when you commission something, sometimes things go wrong during the commissioning phase, and we've had a setback, but I'm very confident we'll be up and running soon.
Okay, thank you. Okay, so I'm nearly half an hour behind everyone, just so.
I'll talk offline to Steve then.
Please, thank you very much. I don't mind us running on because these are important issues, so let's see what we can truncate elsewhere. So I'm just going to reach out. I think Emma's had to step off for a moment, so we'll catch up with Emma maybe at some other point. Steve, is there anything from a Devon perspective that you want to add?
Yeah, I'll be very brief, John, but thank you. Apologies, I can't be there in person today. Probably from our point of view, really interesting to hear some of the discussion, and I would say some of the stuff you're doing around community and place-based work, we're going to want to steal with pride if we can. You'll know that we're still probably quite inwardly focused around delivery of NOF4 exit criteria, but starting to see some room for optimism there. We're at a point now where I think we can see a way through to being de-escalated, which I think is really positive given the improvements that we've seen. And we are sharing some of that work, as you know, this afternoon, particularly around the one plan in Plymouth, which has been instrumental in that. And we've also, with our new Director of Transformation in post, made some real progress now on our out of hospital work. And that's probably the area where I think there's a bit of commonality and a bit of opportunity to work together across Devon and Cornwall. Just in terms of internal news, I don't think it's gone out yet, but it's about to. So I don't think I'm breaking a confidence, but you may be the first to know officially. But we've appointed our Chief Nursing Officer. So Penny has been confirmed as our CNO. And I'm delighted to say our CMO, Peter Collins, starts next week. So also starting to build our internal team, getting our team back in place. And then internally, again, there'll be more to talk about at later meetings as this sort of becomes more out in the open and out in the public. But our internal ICB kind of recovery plan that I've been describing to board is starting to gather some pace, particularly around our culture, values, behaviours. and also the development and bringing together of all of our various strategies into one coherent plan. So a lot going on in Devon. I understand that sometimes we may feel we're looking inward, but keen as we start to move out of some of these big challenges that we absolutely work together on some of the things that are very common between us.
Thank you, and Steve, I'm delighted that you're with us, even if it's virtually, because one of the things which I just want to get some assurance on is, given the fact that 20% of our residents actually go to Devon, is given the fact we have our timeline to December for commissioning intentions, how's that going to work in terms of Devon and what they're doing? So, Steve, are you working on a similar timeline to us, a different one, or?
Yeah, I mean, probably ours won't be as fully developed as yours, but we are intending to have our commissioning intentions out around the same time. It may be actually slightly before.
Okay.
So we're both on the same contract timeline, aren't we? That by the 31st of December, we need clarity around our contracts for 25-26. So the commissioning intentions, they're the front door, aren't they, to the plan that then builds behind it. So.
Yeah, well, that's why I'm just making the point. The December board meetings are pretty critical. Yeah. Okay. I don't think I've missed anybody. Happy for me to move on? Thank you, Steve. Okay, fine. So we're about 20 minutes behind, not a problem, because I think that was important. However, we're about to move on to the integrated performance report, but Susan, it feels like what we're about to talk about in terms of integrated performance report and the item on seasonal planning are like a Venn diagram, heavily overlapping. So we'll deal with both papers, but I think if we treat the topic as one topic, and then we'll conclude the recommendations for each of them as we go through it. Is that okay with you?
Yeah, no, that's absolutely
so
fine.
If you start us off with integrated performance report.
Yeah, I will keep it brief, but I would like to say that I think this is a board more than any other board where we have a very clear common thread. So our IPR also helps us with understanding the direction of travel for our commissioning intentions in terms of patient safety and quality and how we keep our population safe when they're going through our services. So I would like people just to bear that in mind as we go through the IPR. So as we know, the IPR report includes system operational performance against current metrics for the end of July and August within urgent and emergency care. You've made me think, Claire, that I use far too many acronyms. Elective care, cancer, mental health and primary care, all of which are articulated in NHS's single oversight framework and the national constitutional standards. The overview document sets out key headline details, and there's a granular narrative in the pack which I'm not going to go through, Chair. However, areas for note. We've talked a lot this morning about primary care, and every meeting that I seem to have gone to over the last couple of weeks are really clear in terms of commissioning intentions. We absolutely need to have a huge focus on primary care, often the start of many people's journey, and before we know there's the whole prevention piece that happens before people even get to their GPs. So in terms of primary care, we are looking at collating all our intelligence on collective action and how that's impacting all of our services at the moment in a bid to mitigate where we have any gaps and to stop people seeking support from ED, our emergency department. So we'll continue to do that, working with our partners in primary care, and I'm talking about the wider primary care, not just GPs. And we've agreed at our quality and pathway of care committee that we'll take a full paper on the collective action through there just to understand it better, to make sure that any of the actions that we've got in place are the correct actions to support. As you've heard, Chair, our emergency, urgent emergency care remains pressured, and we know that the NHS, from NHS England, their oversight will be focusing on, as part of our H2 meeting, which will probably be happening sometime in November. There are 3 areas that the regional director was really clear that they would focus on, which is the type 1 4-hour performance within our emergency departments, our ambulance handover times, and our category 2 mean times. We know that as the South West, we're an outlier across all of the other ICBs in terms of ambulance handover times and Cat 2 mean times, with Cornwall being the worst. So we have a huge amount of work to do, and our commissioning intentions also includes a lot of the way in which we get ourselves out of this situation. The H2 meeting will also bring in our winter planning as well, so they're going to amalgamate both as we go together. And I have been promised there won't be any long, lengthy templates. However, there will be a template for our urgent and emergency care, just to be able to demonstrate what we're doing, particularly around ambulance handover times. And we do have an exec-to-exec meeting coming up with SWAS, which I think is going to be really helpful to land some of the messages that we need to land, so that we are working collaboratively with our ambulance partners. I think we have better news when it comes to planned care, of which Steve has articulated. I will just touch on, we have had regular gold meetings over the last 2 weeks, Chair. Despite the fact we are in Opal 3 as a system, we've continued those gold meetings twice a week, and we've taken 103 actions that we had across our system oversight meetings, our operational meetings and our tactical meetings, and we've taken it down to 3. And those 3 actions we are continue to work. They focus on no criteria to reside, and it's also the whole of the pathways discharge. So it's P0 as well as P1, 2 and 3, where most of our no criteria to reside work. We've got a lot of work that's going on within each of those pathways, and we'll continue to present that through, because as I was reminded this week, we haven't seen much of a shift when it comes to no criteria to reside. So we do need to push further and harder to really see that impact. We are trying to land, and we are making some impact on a single point of access. So we talk about how confusing it is for our health professionals. It's also confusing for our public as well. So we're trying to talk about a hospital at home model, what that looks like, and our single point of access will be the mechanism by which we will funnel people through the various systems offers that we've got at the moment. And the other area that we've concentrated on is how we use our same-day emergency care to make sure that we are absolutely maximising that investment that we've made as a system into our community, alongside of our community assessment treatment beds and also our virtual wards. And the great news is the clinical summit is really starting to drive that interest with our clinicians about how we get our virtual wards to really start looking after some more of the complex patients who need more oversight but don't necessarily need an acute trust bed. So that's really important to note. Planned care. So you've heard from Steve at the end of October, and I will use that end of October data if you don't mind. 78 weeks, we're down to 2 patients. But those 2 patients are out of our control. There's not much that we can do. There's another issue that's going on, and because it's only 2 patients, I'm not going to go into any detail for fear of any sort of recognition, identification of those individuals. 65 weeks, we are at 54 patients at the end of October, with 47 sitting in orthopaedics, and we are utilising the independent sector as much as we can. And in fact, we've got 35 people left with the independent sector out of a total of 668. So much so the Secretary of State has shown a positive interest in what Cornwall and the Isles of Scilly have done around the use of the independent sector. So I think that's something to be celebrated, and would like to thank the teams for that's
a positive interest for a positive reason.
For a positive
I thought I just really nailed that for you.
Absolutely.
Because what it's done is it's blown the myth, hasn't it? That people in Cornwall won't travel for health.
Yeah, and absolutely right.
And they will if we make it easy for them.
And we
to
explain
travel.
why, and like you say, I will go a step further than Steve went. In terms of 52 weeks, at the end of August, we were first in the region and first nationally for 52-week waits. So I think that is something to be celebrated.
Well done.
I think in terms of 65 weeks, just again to give context, 3rd in the system out of all of the region, and the 7th of all of our ICBs. 78 weeks, 6th in the system, and 18th. So some really good news here. We do know that we need to do more about the 78 weeks, and I think we're just about there cracking that. So I just want to get that across. We're also seeing positivity in terms of treatment for cancer patients. So we are hitting our cancer standards. We did have a slight decrease to 77.9% for our 62-day stand, with the overall target being 85%. However, we have hit the standard for our faster diagnosis, which we know there's an awful lot of people with cancer picked up through that pathway. So I think in terms of elective care and with the elective surgical hub, there's a lot of positive in there, and I think it should be remarked upon, because there's been an awful lot of hard work across the system to really bring that about and make things safe for our population.
Teasing that out.
Mental health, we've had a lot of mental health. We know there's been a deterioration on our out-of-area placement, and that's multifactorial. We recognise the work that needs to be done and would like to thank the efforts from CFT in bringing forward the opening of the intensive care beds by 4 weeks so that we can start to repatriate patients back into the county. It's not... Would you like to say something, Debbie?
Debbie?
Sorry, but we attempted to do that, but our provider has not been able to meet the expected timeline of bringing it forward. So apologies. I think our challenges are understood, aren't they?
They are.
Multifactorial, but just predicting beautifully.
Are we summarising now?
Yeah, so we have got, going back to talking about our COGs and the importance of those, the mental health and LDA group is up and running and working on those transformation, how we get further upstream to stop people hitting crisis. So awful lot of work going on in there. I think that's probably all I'll have to say in terms of our IPR, but it's all there to be looked at. And we've also changed the format of the IPR chair. We're continuing to iterate because we can never quite get to where we want to be with the IPR. So I'll just take a breath. I'm happy to take any
Thank you.
questions.
So, colleagues, I'm not looking out because if hands go up, I want to say something first. So we are going to take in a second the seasonal plan that I suspect will answer some of the what are we about to do as a result of this. So could I just ask you, are there any questions on matters of clarity or questioning on clarification from what Susan has said before we get into the next section about what next?
Yeah, something I've raised before around the performance report, and obviously the focus is on the delivery of services at the acute and trust level, but we still haven't got anything in any depth around the primary care, and particularly as commissioners of primary care, some of those indicators that give the board assurance that also the sort of standards that are in the QOF are being met. So we've raised hypertension, we've raised high cholesterol, we've raised, management of atrial fibrillation, we talked about diabetes, a lot of those done in primary care. If we're going to be looking at a whole system, can I have it noted that I've raised this, I think, at least 3 or 4 times in the last year to sort of see if we can progress that.
Let's note that, but more importantly, what are we going to do about it then? Is that one for Smitesh or for you, Susan, or Kate?
I think Rachel, the QOF metrics, I think we need to have sight of them and how, as primary care, they're performing. So I think it's something we can develop and make sure.
Okay, so I'm going to be slightly more punchy. To be fair to Rachel, she has asked numerous times. So when are we going to have something that answers that question? I don't mind how long it is, but I think Rachel deserves an answer to the question.
Can we suggest by January that we've got it included, because it is monitored? It's not like there's no information. So we'll make sure that we bring forward a report that's got that included in it, and Rachel's right, because when we're starting to talk about our community delivery next year, then hypertension and smoking cessation, I think, are going to be right at the front of the discussions we need to have.
Thank you, Rachel, for raising that. Steve?
2 things briefly, if it's okay. Firstly, just to say thank you to Susan and colleagues for the work on those 3 action areas around no criteria to reside. That's really important. The position for RCHT yesterday, I think, was 120 no criteria to reside patients, which is about 66 more than the plan that we set at the start of the year. So, of course, that continues to have significant flow, quality and financial challenges. So really grateful for that work, which is focused on that. The second thing is a financial one, and I wasn't sure where to raise this, John, so happy to cover it elsewhere if that's appropriate. But just briefly, there are 2 key risks facing RCHT and Steve, that they may well be risks facing UHP as well. The first one is our initial assessment is there is about a £1.1 million shortfall in funding associated with the various pay awards which are being implemented this year. And the second one we've previously raised, which is the shortfall in industrial action funding, which is about 0.5 million. So those 2 things together from an RCHT perspective would represent an additional financial pressure or challenge in year of about 1.6 million. I'm not cited, Steve, unfortunately, on the details of the UHP element, but I think they will be experiencing a proportionate challenge around unfunded pay award aspects and industrial action as well. To a lesser extent, there would be a CFT impact on those areas as well. We're not sure at this stage from a SWAST perspective, but there are, I think those two issues are currently unmitigated at this stage within individual providers' plans and across the system.
To be fair to you, this what you did raise this in the board that we had, and I'm about to move to Simon, so I'll just give you 30 seconds to think about it. I'm hoping that we're able to answer some of those questions now, but let's see. Could you answer the question on pay and industrial action? What is the position on that?
There are two things to highlight. So industrial action, we're having discussions with NHSEI about the value and how it's attributed in terms of us as a system. So that is being challenged, although we're still being told it's unlikely to be resourced. There are a number of trusts throughout the country that are saying they're short on the pay award attributions. So again, there's a discussion happening with NHSE. I've got a meeting with them, with the two CFOs tomorrow to...
So if I can be helpful, just break them into two halves, because I think this is an important point, and I want to be clear on what we also thought came out of the board to board. Can I just deal with industrial action first? What is our position? Are we actually saying it's covered to 500,000 was the number, did you say?
The total financial impact is about 1 million, and about 500,000 is being provided, so that the gap, the financial pressure.
My understanding was the
So in our current understanding around financial position in our CHT, that 500,000 was in the figures that were part of our H2 submission plan. The impact of industrial action is a national issue because it's algorithm based, and we clearly have lost out on the algorithm. So that's why Simon and the two CFOs will be meeting with Jeff Buggle to talk about the impact, that the negative impact on our county. So we'll take that forward as a national issue.
Yeah, on the current assumptions it follows on from board to board. The planning assumptions are that the 0.5 is managed within our CHT, recognising the problem. It's not identified anywhere else, and equally the 1.1 requires discussion about how that's resolved.
So let's play that back just so for the minutes and I understand it as well. Industrial action, forget pay for a moment. Is that...
It's in our H2 submission. It's a known risk.
Yeah, but I want to know... You mentioned 500,000.
Yeah. So within our submission, we know about the 500,000, and it forms the basis of our in-year recovery plans to get to break even. The 1.1 pressure on the pay award is not in the H2 plan in a managed way, and we are raising it with the region.
But industrial action was to 500,000 and no more.
Yes.
Yes, the problem's half.
Yeah, that's not what Steve said, though.
No, Steve said it's 1 million, but 500,000's funded, and 500,000's missing.
I just want to be clear for the minutes.
In our plans, already known, the 1.1 million is new, and we're addressing it.
Are you clear for the minutes? And would you just double check them with Simon before they go out? And are you content with that answer?
Yeah, thank you.
Lovely, thank you. I do want to try and kick some of these things into touch, so we're all completely agreed. Okay. Anything else you would like to add on the money front, IPR-wise?
Only two things, actually. So firstly, to highlight, we recognise there's a deterioration in month 5, but on a positive note, there's assurance behind the month 6 position, which will hit plan, because I've seen the numbers, so we can confirm that in month 6, we would have hit the operational plan we originally submitted to NHSEI. And we've also submitted a system recovery plan as a result of huge amounts of work by our organisations, in particular RCHT, that's being reviewed by NHSE, and we're expecting to get acknowledgement and acceptance in the next few days. And that will give us a revised trajectory to monitor against year, month on month. We're being told it's likely to be agreed, so it is in a better position from a financial perspective. Huge amounts of work, though. Yep.
So at month 6, we were in a better position than we were at month 5, and there was still a collective intention to hit break even at year end. The letter I wrote to Debbie and Steve that lists out the schemes that we need to get action and priority behind are those schemes that will allow us to carry on delivering to our plan and provide a safe and effective winter. So I just want to make sure that we see the two things together, not the money in isolation. They come along with the service change that's required in order to deliver well for our residents.
Yeah. Indeed.
And I think we should recognise, because not everybody's been part of those meetings, what a huge amount of effort has been going on between the teams to get to this point. And I know everyone must think that, but I thought we ought to just recognise that and thank everyone for doing that. Somebody happy with that? Simon, anything else?
No.
Thank you. Patrick?
Well, in view of the conversation, the workforce dashboard that's in the IPR relates to month 5.
Yep.
So it would feel it's a bit, we can take that as read. It has been updated in light of the situation that has just been discussed for month 6. We haven't got the month 6 workforce figures yet. We're in the process of doing that. We'll be reporting that in the normal way. So nothing else to add. I'll take it as read unless there are questions about that.
Any questions? Just to alert everyone, I gave you at the start of the conversation the timeline of 8 weeks to our board meeting in December for commissioning intentions. Clearly, that will be accompanied by our Chief Finance Officer with the financial element, but also the Chief People Officer in terms of Patrick, and obviously Kate as the Chief Exec has been asked to ensure it's accompanied by the workforce element of it as well. So I'm sure there may be more strands, digital or whatever, but at least 3 key strands: the commissioning intentions, money, and the workforce. And then if you want to add anything else as a separate paper or whatever, then we can talk about it as the day goes on. So thank you, Patrick. So, colleagues, I'm going to try and use this as a segue into the next item, but I'm going to say, in terms of the recommendations formally for the IPR, that we acknowledge and discuss, we've done the issues. I think that's been an excellent distillation, Susan, of where we're at. I think we recognise the great work that's been going on, with a lot more to be done, which we're about to talk about. Unless there's anything else, I'll move on from the IPR. Okay?
Thank you.
Lovely. Thank you. So, Susan, you've articulated well some of the issues in the IPR. Let's, rather than look backwards in item 9 in terms of seasonal planning, could you help us look forward for a bit? Mm-hmm. And what are the issues that you feel you need to share with us? Any decisions you need here? Any issues you've got that we could flush out together? Please help us get to an answer here that everyone can be content with.
Okay, thank you, Chair. So just in the paper pack that you've got around seasonal planning, which is our winter update, is just an update from where we were from the last time I presented, which was only last month. You've also got the PowerPoint that was that we had at a regional meeting, which followed the winter letter that came out on the 16th of September, which was after our board meeting. Thankfully, our seasonal plan is aligning quite nicely with the letter that came out, and the winter presentation that we had from Region also reminded us that the plans that we've got both for winter and with sitting within our system priorities and commissioning intentions all align beautifully. You've also got Plymouth have very kindly shared with us their one plan. So working closely with University Hospitals Plymouth is really important, because we do need to land the right services for our population who face into Devon. So in terms of what we really need to do, so I think, Chair, it's fair to say what we need to do is what NHS England want us to do as well. That all aligns. We wouldn't argue with them. So we really do need to support our ambulance service, and in doing so keeping our population safe by ensuring that we keep them on the road, we keep them moving, and we're able to ensure flow through RCHT so that they can do their part in keeping ambulances off the forecourt. We are seen as an outlier when it comes to ambulance handover time, so this is something that's imperative and we need to land. And those 3 actions that I talked about that we've held within gold also ring true to what we need to do throughout the whole of winter. So we did talk briefly about pace. We know that we pick up the pace when we're in System Opal 4. We do need to get into a rigor of keeping that pace going throughout our winter period, because we know what comes with winter in terms of some of our conditions. We're really interested in the one plan with University Hospitals Plymouth, because they are taking respiratory by and large out of the hospital into the community. Obviously, we know our sickest patients will need higher care and intensive care, which is absolutely, it epitomises beautifully what the acute trust is for, and anything else that we can do. And we've used a fairly simplistic view of, if the blue lights aren't on in the ambulance, they don't need to go to the hospital. So what can we provide in the community that gives our clinicians confidence that people are safe, because that's so important. It's often a reason why people don't feel that they can push the envelope, is because of that safety. So we need, as a collective senior group of executives, to be able to give that comfort to our clinicians that what they're doing is right and what they're doing is safe. I had a very recent online conversation with Professor Brian Dolan, who leads the whole PJ paralysis, and he said the question that we should pose to ourselves as a system is not, is it safe to discharge, but is it safe to admit? And I think that's a really pertinent thought to have. So the work that we're doing in the community is incredibly important, and the clinical summit, which we've talked about a lot, giving our clinicians the permission to move services into a safer place closer to home, absolutely aligns with our winter plan, our commissioning intentions with Darcy, and I suspect what we will hear when the national directions come out in December. So I don't want to say a huge amount more, other than I really think if we can land that split between what happens in a hospital, what happens at home, and how we coordinate that through a single point of access, is going to be, I think, a huge bonus for our population.
There you go. So a few observations just before I throw it open to the floor. Martin, just bear with me, to try and help structure the discussion. So I know later on we've got a risk appetite conversation that Mary raised earlier on about sort of similar risks across that kind of thing. We'll get to that in a second, but do you think there's more that we need to do together? And if so, what, in terms of safe to admit? What's stopping us getting to that stage, in your view?
So I think some of the points have been picked up already. It's that coordination of services. It's understanding our services, because when I go on to, we did the regional tier one meeting this week, and there's clearly misunderstanding amongst our own staff about what services we've got, where they are, how often they're open, when they're open, what do they do, what do they take. So I think the clinical summit was a catalyst for bringing all of that together. So I think we need to describe it, Chair, in a way that people understand, and I think that's already been picked up this morning. And we need to describe it to our own staff. We need to describe it to our population as well. And what are the differences going through winter? What is it that we are actually going to do in winter, and how fast are we going to work to land?
So on this point, because
really briefly, Chair.
Yeah, if it's on this point, yeah.
Yeah, and so Susan, I couldn't agree with you more. So I think maybe an offline conversation, Chair, is you've identified what would happen, but the next question is who will, when will, and how will. So to Susan's point, it can't all be Susan. There has to be a joined up system approach of all of those things, and maybe that will come out in commissioning intention and risk appetite, but permission and then the and so what is the thing that makes this real.
One of the things, Nick, based on that challenge, rightly, I would like us to either agree now or find a way of getting it agreed soon after, that Caroline, you can minute. You've made the observation, Nick's made the challenge. Are we agreeing, or have we yet to agree? What's your view on that?
So I think we've agreed what's going into our winter plan, which Kate said it's the first four of the commissioning intentions as well. So I think we have agreement. I think when we talked about it, we've talked about it in system executive. We've talked about it at the clinical summit. I appreciate the level of detail we get into within the clinical, within the system executive group. We don't go into the granular detail. There's a workshop tomorrow around winter. So my plea would be that we allow our teams to do what they need to do, because they know what they need to do. So clinicians make the decision, operators make the moves.
On this point?
Yeah.
Please.
So I think we just need to be really clear that we have a plan. We don't have lots of plans. We have a plan with different strands to it. And I think that's being described in the discussions that are coming together here. The role of this board is to instil hope. So we need to be instilling hope in our practitioners and clinicians across Cornwall and the Isles of Scilly that they have the resources they need to do the right thing by the people they see this winter, The resources are in place. We are in a position of double running. The community has been resourced. We have alternatives to RCHT and inpatient admission. We need to make sure the conditions are right for the hope to be believed and for people to use them. And that's what we need to be asking our clinicians to come up with tomorrow. We've got an exec-to-exec with SWAST tomorrow.
Okay.
SWAST is a key partner in delivering safe and effective services this winter. So we'll be picking up that with them, this one plan.
That's huge assurance. Could I ask then, that, Neil, from your QPOC Quality Committee perspective, you just, once something comes out of that, you just gain assurance and let us know next time that you're satisfied that works in play. So I've got a couple of people who want to speak. I haven't forgotten you. I just want to cover mine off just for a second. You abuse my privilege for a moment. Really pleased that we made as a group the decision to do some pre-commitments a while ago. So I think that was feels like a good decision. But this time last year, when we were talking about there was some extra money coming in, there were some general practice interventions that took a little longer to ramp up for winter. I take it as we did pre-commitments, they're actually ready to go and landed. And I can't see the number in here, but is that all good to go from a primary care perspective?
About the primary care hubs, Chair.
Yeah.
So, I mean, at the moment, they're on course for delivering about 3,500 appointments this month alone.
Right.
And that's just that.
Is that what you expected, Steve?
I was going to ask a different
So that would be
Oh,
supposed to be answering the expected question.
Yeah. Is that what you expected?
That's the expectation we had at this stage. Yeah. The GP collaborative are driving the actual where the hubs and those the sort of the further detail.
What I want you to think about, Chris, is it's difficult to scrutinise fog. So if you can give us some numbers as to what we expect in there, I can turn to Neil in QPOC or Sanj in finance in terms of performance and sort of say, through winter, we expected X to come from our pre-commitments. I just can't see in this report what they are.
So I think we need to pick that up because it's not in this report. So we will pick up all of the things that we specified and we'll bring it back on a monthly basis until we get through winter.
So 2 more observations, then I'm going to open it up again to the people who have indicated it. Later on, we're going to talk about UHP. Are you satisfied you've got enough learnings already? I know the board's going to get some insight today. Are you satisfied you've got enough learnings as to what Derriford's done that actually we can work together to actually roll that out this side of winter? Or
So if I'm completely honest, the work that Derriford has done has been phenomenal. I don't think we are different. I think it's the pace at which we hit that.
That's my question.
Derriford have hit it,
yeah.
And have made huge strides. We've got our place director Trifina Doyle working closely with Rachel O'Connor, and that relationship is pivotal.
So what's stopping us doing it? Call it out.
I'll leave that question open to everybody, if that's okay.
Yeah.
So the beautiful thing about the UHP plan is it's really clear.
Yeah.
It's got one statement around the vision for services that's built on evidence. We've got the same evidence. Biology's the universal leveller. And what they've done in UHP is they've delivered it through line management. So one of the discussions we'd need to have with our providers is, are the line management arrangements in place, that the vision's clear and the belief is there and that it's being driven through the evidence base that we know people who are frail do not thrive within institutional settings, even if it's got the word of hospital in front of it. So and I think, and that's for a collective discussion for us to have. I think we might put Steve and Debbie on the spot if we ask them because they'll say yes, they've got line management arrangements in place, but we need to test our plans against it. Hence my letter that went to both of them a week or so ago.
So we'll come back to that. But Steve, you want on this point?
Yes, so I'm looking forward to the presentation from UHP, and some of us have had the opportunity to have some insight to that already. There are a range of things that UHP have done, which includes a significant expansion of AMU bedded capacity. So just to be clear, John, because you're asking the question, why haven't we progressed? There are some areas, as Steve was alluding to, that our system is ahead, I think, of UHP in terms of some of the community transformations. There are some areas where we can learn and pick up and progress rapidly, and there are other areas where there would be kind of constraints around those aspects. So it might be most helpful to take that challenge into the
completely agree
in the next session.
Absolutely, thank you for that, and I recognise that there's no immediate answer. Okay, is it on this particular issue? Emma?
It's not on that particular issue. It was just a comment for Neil.
I haven't forgotten you. I've got a number of people who
Okay,
want to speak.
no problem. That's fine.
You mentioned a lot in the Susan. You mentioned a lot virtual wards. What's stopping us doing virtual wards of the scale that we aspire to?
So I think we can't ignore the fact that we've landed virtual wards and we've had more capacity than most ICBs. I think the place that we need to go now is we need to push that envelope a bit further to look after people who are deemed. So we get complexity and acuity muddled up. So acuity being the sickest, complexity. We have 3.7% of our population have 7 or more long-term conditions. That's complexity. So there is, how do we push that envelope so that if you take cardiology, for example, with the cardiologist that's fired up, ready to go, our pathways are on a sliding scale. So you'll have the very, very sickest and those that are on the pathway who aren't that sick. So where on that pathway are we able to say, you go to a virtual ward, you will have to go to the hospital?
Who's looking after flushing that out?
So I think that's where we say to our lead clinicians, over to you. We will wrap around you. If you tell us what you need to do, we'll wrap around you. So I think if we can land cardiology, respiratory, and we look at diabetes, because those were our 3 clinical priorities, if we remember. We can't forget that.
Steve, on this point, please. Yep, go for it.
Yeah, really helpful. So I agree with Susan's summary, and CFT and RCHT are already rapidly progressing, particularly following Kate's summary letter after the clinical summits. First priority, rapid expansion and delivery of cardiology virtual ward this month. Second priority, rapid expansion of and delivery of respiratory virtual ward next month. And I was just kind of wondering, John, whether there's a way of building on the work that's already happened. And there's been a huge amount of work in terms of the winter preparedness, but to be able to bring it back to the board that says these are the key strands of work, and as best we can assess, these are the impacts we think each individual bit would have on supporting ambulance handover performance. And I was going to ask in that vein whether we could include within that the actions and the impact that we expect to have around no criteria to reside, etc. I think there's so much work that's been done that we would be able to bring that back.
Very happy with that.
At a high level.
And we can bring that back for next month?
That's the purpose of the workshop tomorrow. So
you bring it back next month. If you could minute that, please, I'd be very grateful. So I stole a bit of time. I apologise. So just so I'm clear who I've got Martin, Steve, Debbie, and Emma. Did anybody else put their hand up that I missed? No. So let's go, Martin.
Thanks, John. I nearly asked my question in the last report, but it was related to ED and ambulance waste, so I'll ask it now. But we just had a big discussion about lots and lots of detail about different plans and things. And I think, certainly from a non-exec point of view, it's been quite exciting to see what's happened at Plymouth. Things can be changed relatively quickly. Ambulance wait times can be reduced. People can move through quickly. And I suppose I don't really need to know all those plans. All I need to know is, are you happy, deliverers, that these are going to be in place in a timely way, as you've said, and that they're going to make a difference, and we're going to be able to see that difference? Is that going to make things safer for us over the winter, safer for our patients, safer for our people? And
Are you happy to pick that up during the UHP presentation?
Pardon?
Can we pick that up during the UHP presentation, or do you want to answer it?
No, because it's a separate thing to the UHP. Okay. These are our plans, the ones we already, Susan has suggested. We're going to be doing SDEX, we're going to be doing single point of access from November. Having got that one plan, as Kate puts it, in place now, have we got the assurance that that's going to deliver for our residents? Or can we assure ourselves?
So I think that's a work in progress. So I don't think we can say, yes, we are assured it will deliver, because I haven't had a response back from our providers in county around the 6 areas that we need to progress rapidly in order to deliver a safe winter. But from what Steve's just said, that cardiology virtual wards will deliver this month, that takes bed base out of RCHT that can be used appropriately. I've looked online, and Rachel Williams, I think, is indicating that the respiratory pathway is definitely up and running and ready to go. So what we need to see, and Hugh Savage has put online, as a clinician, if we want to use alternatives to admissions, my request is to have a default principle, make it easy. So the action that falls to Susan out of my letter is the single point of access. It should be so easy to avoid an admission. So once we've got that in place, Martin, that is when we get the assurance. And at the moment, it's assurance in progress rather than assurance delivered.
When's your next QPOC, please?
Next is the last week of this month. That's the one with a focus on primary care.
Okay. How do you want to catch?
So I think we should minute that for the QPOC at the end of this month, we should have clarity on the 6 asks from system colleagues to deliver a safe and effective winter. The plans, goes back to Steve's point, the plans are in place to deliver that. And then the quantum, the numbers of people we think will have admission avoidance or early discharges. And then we can quantify at the end of it, the so what. Having done all of that, what is the impact on access, which is that where we get the assurance from that flow will occur this winter. So I think if we don't do it by the end of this month, British summertime finishes, doesn't it, on the 27th? Yeah. So we need to make sure that we are winter ready by the end of October.
So if we can feed it through there and for next month, make this a bit of a focus as an update, if that's all right. Yep. Martin, does it answer your question?
To some extent, yes. I think I'd still like to, whilst, you know, it's for you to know, Kate, that there's 7, 6, 3 things, you know, 5 of them are almost in place and 3 of them aren't, but then to make the judgment and reflect it back to us that I'm now pretty confident that as of November, we're going to see some impact. As of December, it's going to be even better. And, you know, we're going to be where we want to be by January or whatever it might be.
So I'm happy to make that assurance statement in our public board next month, once I've seen the work that's come out of the,
Very good.
Of the
that should be.
streams.
So then we're going to go to Steve. Steve in the room.
Yeah, just briefly. Yes, it's very confusing having 2 Steves in the room. I keep trying to jump in when I shouldn't. But just to come back to the point earlier, I think if Mark Hackett was in the room, probably the first thing he would say is, it's brilliant what they've done, and he's really proud of it, and they're all proud. They haven't fixed everything, so it's to bear that in mind. So it is really good progress, but there's still more to do. And of course, for Derriford as a site in particular, they had a set of opportunities and challenges that may be different in Trelisk. So in some ways, the content of what they did, whilst it's important as a reflection, the key points that Mark made about what made a difference were probably 3 things. And I really don't want to steal Joe Beer's thunder this afternoon, but there was something about, in a very difficult environment, getting people's chins up and giving people a sense of hope. And actually that changed the whole kind of approach to this, that people could make change happen, that things could be improved. The second was that there was a really clear methodology about how they approached it. Mark describes it as his goal, method, outcome, but simple, everyone got engaged. And probably the third thing, which may be the most had the most contribution, and it's kind of, you know, no news to anyone, but having positive clinical leadership around the change that was needed probably made the biggest difference, almost independent of what that change was.
You had violent nodding in the room when you said that, by the way, so thank you for that intervention. Steve in the room.
Yeah, Kate, you might not have seen it. Debbie and I wrote to you yesterday just setting out the set of actions that CFT and RCHT are taking to make rapid progress on the areas that we've already touched on. I only mentioned that because you said you hadn't had that response, and just to welcome Martin's challenge about the necessary assurance that we must have as an ICB board to be assured of the impact we expect to see on those actions. I think that's critically important.
Anything else you wanted to raise? Thank you. So we're going to go to Debbie.
Yeah, so I think there's a number of points. The first is that let's not overlook mental health, urgent and emergency care needs in our planning. I know it informs our conversation, but you don't hear it threaded through in the current update. So I had a couple of points. So I think we'll pick up the UHP because CFT are linking in with Live Well to take the learning as well, so we can pick that up under the item. But there were 2 points I specifically wanted to raise. The first is that we all agree that there needs to be quantification of the impact, and that needs to be in providers as well as in the system. So that's the next piece. When we're talking about capacity and alternatives to admission, that's not just what capacity sits within CFT, it's also about what's within the VCSE providers and what's within the council providers. So we've got to have really clear line of sight to that capacity as well, and to be assured that it's available. And then my specific question is around the primary care hubs, Chair, because my recollection from the decision that we made last year and the pre-commitment was that the primary care hubs would be set up to do that, the work that it's set up to do. But there was almost a quid pro quo that this would enable the GPs to work on the red patients that Smitesh has talked about, but that for a number of those patients that would involve treatment escalation plans, and ideally electronic treatment escalation plans that are available as a on the summary care record, because that really would help. And if we were prioritising it for winter, we would ask that we do those people in care homes and in care settings where we know that they may be headed towards end of life. So I'm not hearing the same level of conversation in the winter plan about TEPs this year.
About what?
TEPs, treatment escalation plans.
Calvin's got his hand up.
Calvin.
Yeah, there's a project working on it, which Chris and Susan are aware of. Absolutely, we need to get a focus on driving it forward. And one area where we could do with more help is actually funding the work to actually introduce it into the care homes, because I know that the project team have been struggling with that. They need to prepare a proposal for what they need, but I think it's helpful for this board to highlight that priority and then to feed it back to the project team.
So we need to be really clear then, don't we, how much it's going to cost, because moving people at the end of life to die either in a queue or in an ED department, I can't think of anything worse. So Calvin, can we see that proposal rapidly, please?
Nick?
Yeah, so Chair, really important. So as non-exec or ordinary member, assurance and governance is really important, but please, let's not hang on to the fact that our patients want this to happen. Our clinical reference group or the clinical someone demanded that we be brave. So somewhere in that, let's just hang on to that as we move forward. That's my only observation. I'm not sure I got the answer to my question, but I'm happy to pick that offline of who, what and when. But I just want those points.
We'll come back to it. We won't park it. We'll come back to it.
Thank you.
Earlier on, I mentioned the fact that there'd be commissioning intentions, a finance paper and a workforce one. Just hearing that, I don't know whether you want to make sure it teases out in commissioning intentions or whether, Kelvin, you want to have a separate digital element. I don't think we should get to December without being clear what the implications are, whether it be money, resources or whatever else that require solutions based on digital solutions.
You're talking 25, 26
Correct.
for commissioning intentions.
Yeah.
I think we also need to have that for our winter plan, so that we're very clear how it will roll out.
Challenge. If we could minute that, I'd be very grateful. Thank you very much. Okay, colleagues, so I'm going to go to the recommendations now, if that's all right. So I won't read them out. You've got the two recommendations there, which I hopefully you'll support in this paper. But don't forget, we've got the third one that we picked up, we went through, which is getting that feedback, Susan, via you, both for in-month for this year. But we're also going to have the numbers for general practice and other delivery items as part of that shared.
Yeah.
Anything else you feel I've missed on the recommendations? No?
So I thought Emma had her hand up.
Oh, it went down, that was all.
Oh, and it's still up.
No, it did go down, but Emma, yeah, go for it.
Sorry, I think Teams virtually put it down because it's been up for a while, that's all. So obviously got achy. Just really quickly, it's just an action, if I can be so bold as to ask for Dr. Walden and myself, because QPOC's coming up at the end of the month. I think a number of things you've touched on today, particularly around general practice and SWAST interface. I've been on a meeting yesterday with my other LMC colleagues in the Southwest with SWAST team as well. So there's a lot of work going on that we're all doing little bits of from our own perspective within the community. And it'd be really helpful, Neil, I think, for you and I perhaps to have a very brief meeting outside of this, just to kind of to inform you of the bits that might be useful, even if I'm not able to come to a future meeting, which I would hope that I could. Thank you.
To share with you, Neil's violently nodding, so catch up afterwards, yeah? Lovely. Happy to finish on that one? Yeah. So, colleagues, I think that's been a good conversation this morning. I do think it's important to have a break because we get refreshed and then going. So can we pause, where is it now, 10 past? Can we come back and literally start at 20 past, please? Thank you very much. We'll break there now, colleagues. Let's pick this up again. Just to explain where Sanj is. Sanj is actually dealing, you know, he's chief executive of Shelterbox. There's a rather major hurricane that you may have heard about elsewhere, which he's doing his day job on. So he's running late, not surprisingly. I wouldn't be surprised if he wasn't here at all. So I'm going to ask Martin, when we get to some of the FMP issues, because you attend FMP, if you could stand in and suggest as we go. Okay. So in terms of the next item, which is item 10, monthly SIP update. So you've had the paper. Simon, what would you like to add?
All I'd say is we have added a lot more detail in terms of tracking delivery across organisations in the system. It's part of our system recovery arrangements that are well established now, I think, in terms of reporting, and also the position in month 6, as it does at the bottom line, is improving. So we are moving in the right direction. There's still a lot to do, but the mechanisms are in place to support and report on delivery to this board and to our various committees. So there's nothing else at this stage, but happy to take questions, John.
And I think if I can just help people look toward the recommendations, when it says the overall risk of delivery is classified as medium, that's for the full year.
Yeah.
Yes.
Just, Caroline, if we can just minute that when we get there, that's medium for the full year financially. Okay? I'm not going straight to the recommendations. So are there any other points people would like to raise on SIPs that hasn't been talked about before? Anything that came out of FMP, Martin?
No, I think what I'd say is, the FMP went through this in quite a lot of detail, and we're, reasonably assured now that there's a good level of grip and control, a better PMO, much better level of detail and understanding coming through. So we'll monitor it going forwards. Obviously, as Kate said, some new risks coming to light as we go through the year, but happy thus far that we've got a better view on it, I'd say.
Mary?
I think, Martin, but I think it might be helpful for the board to hear how RCHT board has been addressing this, and that we've been on top of it in a great deal of detail. And I think I'd endorse what you just said, Martin. I think we've seen a quite significant, not shift, but development of things that were already being done and intensifying, and that grip and control. And I think our whole board at the moment is satisfied as to where we are.
I hope this comes across as positive as I mean it, and a notable shift of scale and pace. So thank you for that. That was the feedback we were getting from that FMP, I think, was the assurance element. Rachel?
Just because I know Tan and Emma aren't here, I think they both maybe would say, can we explain some of the acronyms for people who may be new to the board and the public? Because all I've heard is SIP and FNP, and I know what they are, but possibly other people don't.
Oh, okay, that's a fair challenge. So Cost Improvement Programme, SIP, and Finance and Performance Committee for FNP. So thank you for good challenge. Can I ask, again, Mary, something that you mentioned earlier on, which we're going to talk about later on in terms of risk appetite, but let's maybe talk about it now because it's in the recommendations. Recognising the level of risk of each part of the system and the overall risk generally. So what's our perspective on the different parts of the system? Because it's not just RCHT. So how do we get some sense that might be helpful now in this debate, that might help the debate on risk appetite in the moment? Are there any elements you want to raise now as part of the SIP element that say, because Susan, you raised the issue earlier on about ambulance, and then you're going to have an executive group with SWAST coming up. What are the elements here that are the risks that, by not having a risk appetite aligned, that's getting in the way?
I'm not sure this is quite answering your question, but there are some elements of risk that aren't described in our current CIP paper. So we know that general practice in some parts of Cornwall is really starting to feel financially precarious. And so the work that we're undertaking as a team is how we ensure that general practice can be strong and universally available, which is what we need it to be. I don't think in our CIP discussions we actually describe the level of efficiency and productivity that general practice is absorbing on a daily, weekly and monthly basis. And I think perhaps we need to pick that up, because if general practice falls over, that will have an adverse effect on the ability of the rest of the system to deliver their CIP. So I think we might need to think about how we reflect the totality of our CIP risks, not just the NHS contracts.
Caroline, will you note that, please, so we can have a...
Just on behalf of Nick, pharmacy as well, similar sort of pressures.
Agree.
Yeah, thank you for my, I'm conscious of the hats I wear, but the other collective actions and ballots going on, but thank you, Martin.
I was just going to say the same thing, Kate. I really appreciate that. But yeah, obviously, as I'm representing primary care, the same goes. I did put in my brief paper around, the number of pharmacies that are closing.
You speak up, I'm sorry.
I did put in my paper about the number of pharmacies that are closing as well, and dentists that are having, similar financial pressures. So yeah, it would be important to try and include that in our cost recovery or cost improvement plan.
Okay.
Can I comment on that as well, if that's okay?
Yeah.
On the risk position. I think some of the things that Susan outlined earlier on were really helpful. And part of our challenge, I think, is the ability to be assured that where community services can have an impact, they're available consistently 24/7 or 7 days a week, or whatever the mechanisms would be. And I think Susan was giving examples of patients in ED to an extent because there isn't the stability or consistency of services elsewhere. So I think that's part of our challenge, and there's a set of actions underway to address that. I think we've had a couple of examples of the challenge in progressing those areas in terms of pharmacy capacity risks, primary care capacity and risks is a challenge for us. But I was also struck by something Susan said about when you were talking about is it safe to admit, which I thought was really, really powerful. To me, there's the same question about is it safe to convey? Because at the moment, if we're conveying a patient to the emergency department, when we look at the ambulance handover delays and the length of time you'd spend in ED before any onward form of care, I think that same principle could be a good challenge to all of us, not just from an admission perspective, but from a conveyance perspective.
So I think that the linking of these points is what we should be calling dynamic risk management. So we're good at dynamic risk description. We're less hot at taking the actions that are required to reduce the risk. So I think that's a really good point, Stephen. We will pick it up with SWAT tomorrow, but SWAT paramedics need to know that we are supporting them in making appropriate decisions in people's homes, even if a GP or a healthcare practitioner has told them to convey. And the single point of access will be their safety mechanism so that they know that they are supported by the system for doing the right thing for people.
Okay. Last word to Simon.
Just going to add to your comment, Kate, on the improvements and contribution made by primary care and community. That sits very well alongside the work on channel shift. So us demonstrating better care, better value as part of the exercise we're doing, obviously focusing on the next 8 weeks will partly answer some of that, and we need to demonstrate it to ourselves as well as to our communities. So it's just about that. Thank you.
Very good. Okay, so let's move to the recommendations. We're noting the detail. We've had a conversation around that. We've recognised the risk at each part of the system, and we're changing the recommendation to be risk delivery classified as medium for the full year. Okay, everyone happy? Done. Thank you very much. So let's move on to productivity. So again, you've read the paper. Simon, what do you want us to take out of this, please?
Again, I can be brief on the basis people who read the paper. This is simply a reflection of the national report coming through that shows the month 3 position, and productivity is that sort of weighting of cost against service levels of service activity. And we've all been highlighted and focused on nationally the deterioration of that since 1920. In the month 3 numbers, which are what are reported here, and that's the sort of, there's a 2-month time lag when it comes out from the national team, highlights a minus 18.8% on productivity and it is primarily for acute, so for RCHT. We do, however, ask to note that there's a huge amount of work being done to reprofile the costs, etc., for the end of this year, which is part of system recovery, which will give us a better picture, prospectively, of what will be happening. We are anticipating, and I think we've had early sight of an improvement being reported in month 5, but nonetheless, I guess the understanding around productivity, the causes of it, and how things can improve and contribute value to our system will continue to be a focus. Besides that, I have nothing else to add, John. Thank you.
I think one of the things that came out of FMP, Martin, from memory as I attended it, is that I appreciate these are validated numbers to month 3, but we do have more recent information. Is there any reason why we can't have validated and then latest informal update?
So subject to our providers agreeing, we could bring forward a validated position and in time period position.
Because there's a better news story than this, is all I'm trying to get at. And would you be happy with that as a...
Yes, and not just if it's a good news story.
No. Okay, fair challenge.
So I think the short answer is yes. It's not a caveat, but depending on when the time of that report coming out, it might be that there's little additional context that we can provide if the report has only come out in the last couple of days. But I think you're quite right, and Simon is as well, to signpost that we're expecting the month 4 report does show a significant improvement. And I think there is a lag because of the nature of the way in which productivity is calculated for us to see the impact of some of the...
I just think it's a shame, Steve, that at FMP it's informally shared and yet it's not shared with the board. So I just think if it's having that informal conversation, then whether it be good, bad or indifferent, it would be helpful to share it here, if that's okay.
So it could, and Simon, if you were content, that could be shared as a slide deck immediately following the board and summarise the...
But it would need to go through FMP first, that would be the deal.
Yeah.
And you and Debbie and your chief execs, your CFOs are invited to the ICB one, so what goes there you can see and make sure the language that comes out of that is okay. Okay?
Yeah.
Yes?
So in the paper that's in front of you, in the first paragraph, final line is the CIP in 2024-25 includes circa £10 million of I'm reading something else. What I wanted to say was we've got £10 million of transformation schemes in year that currently they aren't delivering. Now those £10 million of transformation schemes also happen to be the schemes I wrote to Steve and Debbie about, the response that I've got around where they'll be picking them up, our winter prioritisation. So everything we're talking about in this board is hitting exactly the same area for cost, income and outcome and quality. So our triple aim is being delivered. I would just want to remind everybody all of the time there is only one plan, and our CIP delivery forms part of that plan. It's in the middle with everything else being delivered around it.
Okay to move on?
Can I just raise something on productivity? Yep. So from a mental health perspective, at the present moment, we've always acknowledged that this data is acute focus. Yep. But we've been doing some internal work to ensure that we understand where we sit with mental health. But I understand now that nationally they are looking to introduce mental health productivity data reporting for the next financial year. So it's probably something to expect to come through in the operational planning guidance. And again, we might want to reference it in commissioning intentions.
Very good, we'll come back to it. So I should have done an introduction at the start. Now, Hester, on the screen, you're standing in for Rachel. Welcome from Region. What would you like to add?
Thank you very much. I suppose I first feel like I need to apologise on behalf of NHSE. You've mentioned a couple of times in the meeting today about acronyms, and I think this has the most acronyms I've seen in any paper ever. So apologies for that. It is very, very technical. I'm just conscious that all of the work you've been talking about today, the seasonal planning and the commissioning intentions, alongside that work you're thinking of doing about reprofiling this for month 5, month 6, are you also going to be doing something like, so I find the waterfall diagrams which are on slides 23 and 24 possibly the most helpful bit. Are you planning to do any of that at the same time? Because I think that just might strengthen some of those actions that are already underway in the seasonal plan and commissioning intentions, to know where to there might be a focus on a particular area, or where to look or where not to look.
I'll tell you what we'll do, Hester, if it's all right with you. Can I get Simon to get in contact with you afterwards and give clarity on that rather than nail it here? I think one of my observations is this is great and there's a lot of it, but it would be nice to have a helicopter pack that actually just gave a very high level bit of signposting. So maybe, if you could pick that up as well.
Thank you.
When might we see mental health productivity numbers, do you think?
So the team are talking across, so AD and Simon are talking about the work that we've done.
Next month?
So I would need to look to the two finance guys. It's not going to be reported in the same way as this.
No.
So there's two separate things over there. There's local data and there's national data.
What we're trying to do is ensure that the two things are aligned.
Okay.
So I would think we'd better give you an update in 2 months' time.
Lovely.
So we certainly expect as we get towards 25-6 plan, we've got some more.
So could you minute December as an update? Thank you very much. Okay, colleagues, let's move on to the recommendations here. So we've got to note and receive the productivity assurance update. Everybody happy?
Yeah.
Done. Thank you. So I'm going to help with 12 as Molly's not here. So this, if I'm going to take you straight to the risk statement, which is on page 2, the risk appetite statement, which is the second paragraph, effectively. Overall, the Integrated Care Board's intention is to minimise the risk to commissioning of quality services, the IC Board's accountability and compliance frameworks, and maximise performance and opportunities to service transformation. One of the things that's been in here, there was an informal workshop on risk. Personally, I didn't attend that. And that was a moment in time. Now that we're moving towards looking to the commissioning intentions that we'll get onto in a second, this is looking to sort of say you need to have a risk appetite that actually guides and helps the speed and scale of our risk commissioning intentions. So we can have a discussion about on page 3 as to whether it's seek, minimal, cautious or whatever. There's an element of finessing there. But I think if we come back to the core statement, which is minimise the risk to commissioning of quality of services and maximise performance of opportunities and transformation, then I think that should be a test that we should take into the discussions. Does anyone wish to disagree with that statement?
I ask a question about it, John. My only question is really, is it minimal preference for very safe delivery options, or is it seek? And seek might be too far on that range, but when we think of the transformations that we have in train going forward to deliver the overarching outcomes that this board has, they are very significant. Really,
you're talking page 3 here.
Well, yes.
Yep.
So it's that kind of overall definition where we're saying a minimal risk, and whether that is right. I don't disagree with the focus on quality and safety, but we are transforming models of care. And we've had a number of examples from board members about the ambition, the intention, and that doesn't feel like a preference for very safe delivery options. That feels like a willingness to consider radical transformation. So my only question was really, have we framed that risk appetite to reflect the ambition the board has for transformation?
I'm delighted to have the discussion, because before this paper went out, I think where you're going is minimal, cautious, doesn't reflect our ambition.
Yes.
And therefore I'm more than happy to get the board's review on that now, and that's why we've got the paper to move it. I won't lead you, but I am completely in your space. If we're going to have the ambition of here, then the risk appetite needs to reflect there. Nick was next.
Yeah, so I think Steve's point is really well made, but I would challenge that a new model of care doesn't mean unsafe. So actually, and if it does mean unsafe, then there are mechanisms in place that would mean it wouldn't happen.
Yep.
So I don't think radical transformation means unsafe. I need to say that out loud.
Yep. So you're agreeing it's not really minimal?
No.
So you know, a new model of care isn't an unsafe model of care, it's a new model of care.
So I think it depends how you read it. So how I'm reading this is that we have a very low appetite. Yeah, no, I know. So having to minimise the risk of the commission of quality services. I agree. We should have a low risk to allow poor services to be in place. However, radical transformation could be the mitigation to the poor quality service. So I think the way I'm reading this is that our intention is to minimise the risk to commissioning of quality services. So we're going to minimise anything that will have a bad impact on services for our people. And we're going to maximise performance and opportunities for service transformation. So they're my yin and yang together, really. We'll maximise the risk tolerance for changing something and minimise poor outcomes for our people, is how I read it.
Yeah, so part of the reason why I felt these were two ends of a problem that didn't really match in the middle is the language on the left, on page 2, minimise and maximise, are not the headings of minimal, cautious, etc. on the...
Oh, right, okay.
So I buy the statement, which is minimise and maximise, but I had a problem with the allocation of risk appetite, which I think Steve's got, on the right-hand side. So I'll just throw it out there. I think, only me, that we have a collaboration and partnership of SEEK, but I'd be disappointed if everything else wasn't open. Why would we not be open to improving value overcomes and challenge providing care and support? Why would we not be open to transforming care to responding to challenge needs? Why would we not be open to operational recovery from pandemic? I don't understand why we would so cautiously or minimalise it downwards. I don't get that. So I think there's a couple of seats and everything else should be open. Discuss. Non-execs, what do you think?
Yeah, sorry. I suppose when we assess risk, what we don't do is assess the risk of what we're currently doing at the moment. And I think the reality is if we don't increase our risk appetite with the way that demographics are going and with the way that demand is going, we have to do something different in order to change.
Thank you.
In order to change the quality and equity of outcome.
Yeah, so I would agree with that, Chair. You know, I think and I think Steve reflects that in his comments. You know, there's lots of people making things about our risk appetite being of that which, you know, demands transforming of care. I can see where you're reading it and the way in which you're reading it, but I would still come back to the conversation that, you know, a new model of care isn't an unsafe model of care. But I'm happy. Yeah, my personal risk appetite is, you know, we need to get this done and we need to get on with it. So
I'm going to ask Martin, Neil, and then I'm going to ask the advice of the Chief Executive as to what we should do, and then we'll get together. Martin.
I think I agree with all of your proposals, apart from perhaps, you know, the statutory and regulatory compliance, which, you know, perhaps that should stay cautious rather than open, given, you know, that covers such a multitude of things, you know, lift safety, fire extinguishers, you know, that...
Okay. That's why it's a discussion. Thank you. Neil, what's your view?
That I was like you, I was a bit surprised at minimal in places. I thought it was more of an open approach to
okay, thank you.
The problem with us filling these things in is that I think if you're not used to it, it's a very difficult concept to understand. Yep. So I'm worried that when we did the exercise, it's been somewhat lost in translation.
Yep. Agreed. Rich, what's your view?
Yes. I guess I just keep thinking about the what if something happens thing.
You have to speak up, I'm sorry.
So I guess it's just thinking about a specific example, isn't it? So minimising something and maximising it, to me, it's always about a trade-off. So if we were to push maximising, we might not be able to minimise. Would we accept?
Stick with the headings of minimal, cautious, open, seek and significant now, please.
Those areas. Then I would agree. I think the regulatory one.
Okay, we'll stick with the regulatory one. Claire?
Yeah, I think so.
Stick with that. Chief Executive, what's your advice?
So I think I agree with Neil. I think some of the translation of the great workshop we had hasn't come out in this statement. So forget the risk appetite statement on the left-hand side and just look at the box. I think given where we are around the imperfect shape of accessing care in Cornwall, and my reading of the risk appetite being none is like low risk up to significant, prepared to tolerate a high risk, I think we should have significant in our risk appetite for some things. So collaboration and partnership, we should take significant risk in making sure that we can find new partners to deliver in different ways, which is what we're already doing. Transforming care to respond to change, we should be taking significant risk to be making sure that our service models reflect the needs of our population. That's not to say it won't be mitigated and managed significant risk. Improving value should be significant. So if we go down them, digital, I don't understand enough about risk and digitisation, so I would defer to Kelvin.
Okay, we'll give him a chance in a second. Operational recovery?
then we should be taking significant risk, because if you're the clinician that's being asked to discharge somebody and you don't think they should go, you'll feel it as significant, and we should be managing it with them.
So I'm going to summarise in a second, but what's your view on digital?
So digital, we actually, as Kate's saying, we actually don't view it as a single thing. So for clinical systems, we are absolutely open to digital supporting transformation. And the way that we manage the risk is that we have to complete statutory safety cases. They cover not just the technology, but actually the people issues. So how the pathway works, how people are trained. So actually, in many ways, our safety case gives you the mitigation.
Significant.
So we're potentially open in
Can I push back a bit? Given Darcy's and the Secretary of State, one of the Secretary of State's 3 pillars is, I'm going to use my language, analog to digital. Why would we not be as significant in digital as part of our transforming care for needs? Why would we have a difference?
I don't think it needs to be significant. Open actually gives you the ability to do it, because you explore the options and pick the options that
okay, so
work. Where I'm really cautious, as everybody knows, is cyber.
Yeah,
risk
okay.
appetite is much lower.
Okay, well, we'll note that. So I'm going to summarise what I've heard, and then you can shout me down. So I'm hearing, okay with the statement, because it uses the word minimise and maximise, and then on the right-hand side, on page 3, improving value is significant, transforming care is significant, operational recovery is significant, collaboration and partnerships is significant, statutory and regulatory compliance is cautious, and digital is open. Everybody happy with that?
Yes.
Lovely. I'll move to the recommendations then, thank you. So we've got the BAF in here, which we've all had a good chance to read. Incorporation of the SIP report into the BAF going forward. We're going to adopt the risk appetite statement, Caroline. But will you note, please, the changes that we've made to the risk appetite statement definitions by strategic objective to what we've just talked about?
Can we make an additional point?
Yeah.
That in understanding our risk appetite by strategic objective, we need to read it within the context of minimising risk to the quality of services whilst maximising the performance and opportunities for service transformation, because they need to be read together to make sense. Steve's got his hand up.
Yes, Steve.
So I support the summary from both you and Kate. Just wonder whether we come back to this as we finalise the plan for 25 and 26, just to test whether we delivered the plan in the way the risk appetite says, and also whether we need to refine the risk appetite in light of kind of emergent.
We capture that, Caroline. You know what? People think this stuff is boring. I get excited by this. I might need to get out more.
It's a brilliant workshop then, because it was fab.
I need to get out more, but I'm feeling enthused by our general appetite to want to go forward. Neil?
Just an observation. It interests me that there was the workshop, but if my recollection is correct, there were some limited numbers at that workshop, and perhaps it demonstrates the need for the confidence that senior leadership gives when you're talking about risk.
Okay, noted. Thank you very much. Let's move us on. Modern slavery statement. You've had the paper. I'm going to move us straight to the recommendations. So the board is asked to approve the content of the slavery statement. I can't believe no one's going to not support it, so I'm going to get your...
Please do.
I was going to say, all right.
It is a statutory function.
Yeah, well, that's why I didn't think this one would take too long, if I'm honest with you.
This has been approved.
Yep. I shouldn't be flipping on something so important. And approve the modern slavery statement and its adoption by the ICB for the 24-25 period. Everybody happy with that? Lovely. Thank you very much. So we can move on. So, 15 minutes behind, not doing too bad. Commissioning intentions, everyone. Well, we've got the opportunity twice today to talk about this. So if we take a bit more time now, means a bit of time later on, not a problem. But let's have a structured, calm, respectful discussion around what has been. And I'm going to steal a quote from Churchill just for a moment. Don't forget the document you've got. This is not the end. It's not even the beginning of the end. It's just the end of the beginning. All right? But where we will end, hopefully, is actually going to be at our December board meeting. So we have an 8-week window, and I'll start at 10. So thank you to the team who've produced this. Susan, would you please take us through it?
I do love a warm-up act, thank you.
That's all right.
Thank you, Chair. So I'm aware that I'm the slot before lunch, so I will get through this as quickly as we need to. However, I have to say that there was some trepidation that I had before taking this, even more so than the IPR, which I usually dread. But the amount of agreement in the room for everything that we've discussed so far, I think is crystallised in our commissioning intentions. I think everything that we talked about, whether it's winter, whether it's finances, whether it's our IPR and the current state of our services, it's all contained within our commissioning intentions. So I would be surprised at any violent disagreement, given the level of energy, I have to say, that's been in the room this morning, which I think has been fantastic. And it's great to have a common thread that's gone through all of the papers that we've had this morning. So I won't labour the strategic commissionings, the link back to the Darcy report, because Tracy went through that all at the last board. So I feel it'd be much better to have an open discussion about what we've put before you in the slides in terms of how we're doing it. However, before we do that, I would just like to go back to Steve, your comment about what is channel shift. It's a really good comment, because I get this a lot. What is channel shift? What does it mean? And actually, when you read the commissioning intentions, it talks more about redeployment of resources. And it's redeployment of resources as a logistical function to something, to a plan that is going to improve people's outcomes and their experience. And the benefit of that is the value. It's the value of the patient experience and the family experience, and it's the value of our staff in being able to do their job and feel that they've done something. But also there's a financial value, and we can't escape that given the place that we're in at the minute. The commissioning intentions are an opportunity for us to redeploy our services that are all in line with those Darcy report, that talks about how we move from treatment to prevention and how we go from analogue to digital. And that's what this plan is about. It's not to catch anybody out, and it's to give us some of those efficiencies. And I suspect, having done QUIP programmes before, in other parts of the NHS, we may not find immediate savings, but it's the right thing to do for our population. It's absolutely the right thing to do. And again, I'm going to quote the clinical summit. Our clinicians tell us it's the right thing to do, and it's what they want to do. So I don't think we'll get any argument. What I do accept and take on board is the amount of detail that needs to go into this to assure my colleagues around the table that this is absolutely going to give us what we need to shift the dial on how we free up our one main acute trust. I know we have UHP across the border, University Hospitals Plymouth, but our CHT is our hospital, and we need to make sure that we support it to be able to look after our sickest people and those people that need it, whether you're having a baby or whether you're having an operation. It's incredibly important to all of us. It's an asset we need to protect. And our patients will tell us, our people will tell us, being in their own home with good care wrapped round is their choice. That's where they want to be, and that's what the commissioning intentions is looking at. The other area that we cannot move away from and forget about, and Patrick gave us a very compelling paper, I think, at the last board about workforce and the numbers of young people coming through to service our needs, whether it's health and social care. We don't have enough. So we do need to grasp that opportunity in digital to say what functions can we embrace that digital can really lead the way on. And that also brings about an efficiency for people's time. People tell us they don't want to come in for outpatient appointments. They don't want to be dragged up to the hospital. We know the bus routes in Cornwall aren't the easiest to navigate. So we need to take that into account as well. So the commissioning intentions tell us in the slides, Chair, what part of the three objectives we are hitting, the work that we need to do over the next 8 weeks, and we need to do with our providers. This is not something that the ICB, as I say, small ICB, the 300 of us, are doing. This is what we're doing collaboratively. And the programme of care leads are pivotal. So we are working with our programme of care leads to get into our providers, to work alongside managers, to work alongside clinicians, to say, this is what we're thinking, this is what the population data is telling us. What are your thoughts? Because invariably, clinicians and people that are doing the jobs will have the answers, not people in rooms, in offices. So this is, as you say, it's the end of the beginning, but we've got a huge amount of work that we need to land. And I think the discussions that we've had this morning fill me with hope that we are absolutely on the right track.
Thank you. So to help try and structure the discussion, I was hoping that Margaret, who I know was on the call earlier, but if you could pass on our thanks to Margaret, because she gave us the challenge last board to actually define what channel shift was, which is defined here on page 15 at the top, which is a great thank you for that. I'm just wondering, Susan, whether the way to structure this is to jump to page 15, 16, 17, etc. And just for a moment, stay in the helicopter, go through each of the key headings and just ask colleagues generally, as it's a unitary board, what are your thoughts on this? One of the things that I would like us to see as we go through November and December is what will be different with the numbers, resources, pound notes, what will be different, places, whatever. I don't mind, but, you know, I said earlier on that we'd ask Lucy to bring this alive in the vignettes kind of things. Again, I'll rather rudely put it this way, you can't really shoot fog, all right? But if you can actually shoot something that actually, because I can see it, I can get what you mean, we need to articulate beyond the principle into the detail. So would you be kind enough to lead us on page 15 first in a discussion open to everyone about urgent emergency care, intermediate care? You've got 4 points down there, you don't need to talk about them, but can people give any thoughts on, are you happy with what's on page 15? Is there other things missing on page 15?
John, I'm not sure if your page numbers are
struggling with the page number.
It's 17 in the electronic, but 15. Yes, slide deck. Number 15, 17 in the.
Go to the one that's actually headed lead program towards the very back end. It's the final slide deck, looking like this.
Landscape.
Landscape.
Page 19 on
okay.
Version.
Yeah, I'm still analog, Kelvin, as you can tell.
We need to shift you.
Smitesh.
Thanks. Yeah. There's a couple of points there that I particularly wanted to address. I guess number 3, I'm all for working in integrated neighbourhood teams and moving primary and secondary care together to make the system work better. My concern, I guess, from a primary care perspective is how does that look in terms of a shift in resource? You know, what does that look like? Does that mean I have an ED position out in the community, or you know, what kind of things are we looking at aside from what we already have? And I guess the second thing that was a little bit surprising to me on that last point was developing a model of care for people over the age of 65 at the end of their life. I'm not sure where that figure sort of came from, but I think if we tried to look after, and I'm not saying that in some cases that's not appropriate, but as a clinician on the ground, we tried to look after everybody above the age of 65 in terms of their end of life care, that would spill over into a huge amount of work out in the community. And that may just be an issue of, you know, figuring out what that number is as an arbitrary number. I know we have to have a cut-off at some point, but maybe there need to be some conditions around that. And again, attached with that, and I understand that you said that there is a lot of detail that needs to go into this, and certainly, you know, looking further ahead from the primary care perspective, there is significant detail that I and the rest of the primary care team will probably be able to contribute. But from that perspective, it's looking at from these 2 points, you know, okay, how does that look?
Susan?
Okay, so if I take the last point first, so I've been on a few meetings now, Smitesh, where I've had some very difficult conversations about, are we rationing care? Absolutely not, and it doesn't mean that we are not looking at other age groups. But what our data tells us, particularly when we look at our presentations into ED, it's in that over 65 and up age bracket. So you're right, it's really difficult. You have to choose Rather than trying to eat the whole elephant, you've got to choose part of it. And the data tells us that's where we need to be looking. So I said earlier, in Cornwall, 3.7% of our population have 7 or more long-term conditions. They are people who find themselves in our acute trust more than they should, because there is nothing else that we're offering them that runs 24 hours, 7 days a week. So that's the reason. What we can do through the work that we need to do over the next 8 weeks is break down what that over 65 cohort looks like. But we know in that our really poorer neighbourhoods that frailty affects people who are younger. We know that. But we have to choose, and we have to say this is where we're starting. The commissioning intentions, whilst we're talking about the rest of this year into next year, we do need to be mindful that this chimes with our joint forward plan, which is a 5-year plan. So there are things on here that absolutely we need to land here and now, and there are things that we're going to land slightly later. So that's the reason for the over 65s. And I just want to make it really clear, we are not rationing services. We are not just choosing an age group. It's what our data is telling us we need to look at. And of course, we'll work with our primary care colleagues to refine that even more, Smitesh. But it's a starter.
Okay.
One of the things we know is if you've got a diagnosis of cancer, we're quite good at all your care, including end of life, because we know what you're dying of, and we often can work out sort of when. Whereas if you're frail, and we don't know whether this chest infection will be the last chest infection you'll have because it will lead to pneumonia that will cause your death. We offer really quite poor services for people who die of non-specified conditions, and this commissioning intention is trying to pick up that everybody deserves the right to a great death, and that is death in your own home. And I think underneath this will be the fact that we need a range of community services. That means no one has to go to hospital for pain relief, and it doesn't have to be your GP that gives you it at 4 o'clock in the morning. So I think that's just pulling together some of the value around our commissioning intentions, as well as the actual words of describing the scheme.
Yeah, I appreciate both those responses. I guess the additional thing that I'm sort of trying to point out here is that, along with things like Brave AI and patient segmentation, that needs to come along with this, and along with the development of our sort of palliative care and hospice at home services.
Yes, Smitesh, what would you like to see changed?
So I think it's just including that this isn't just urgent and emergency immediate care. It needs to be coupled with, if we're going to say that all of the age over 65 end of life are going to be looked after here, then it needs to be coupled with the development of a 24/7 palliative care.
Yes. So that's what the model of care is. So the model of care is a 24/7, 365 days of the year service. And the reason why it's described under UEC is that's where we're modelling the activity at the moment. So we can say how much money we're going to save by providing much better services for people. So in mine and Susan's language, that's a QIP, a quality improvement, prevention and productivity saving, not a SIP. It changes something for the better and releases a saving.
So we've got a few questions now. Rachel?
Yeah, thank you. I've got to go quite quickly, so I was just going to make a comment generally about commissioning intention. So, the front end really aspirational about shift to prevention and preventing ill health. But then when we move to the commissioning intention summaries across the programme of cares, I don't see anything that is really substantially a prevention approach. So I'm happy to talk to colleagues, and I know I would come through to Chris and Susan about maybe articulating that in, because if you're saying it, then you're not doing it. That does seem there's a bit of a dissonance there. So I think encourage you to be a bit more specific about some things that could be achieved. It's not the job of public health to do all the prevention. It's everyone's business, and I think if you said it, we need to put it in. And then I guess a question about cancer screening, is that coming as a delegated commissioning area and specialised commissioning? I know, Kate, you would be, that's not in there at the moment. And then Ali, I know, is on the call, but in relation to reference to joint commissioning and the start well, live well, age well, as part of commissioning intentions, wouldn't it be great if there's it doesn't, not the detail, but the reference to the areas of joint commissioning that we're all committing to doing together? And health inequalities as well is very name but not specific. So again, I can pick that up with Chris in the next 6 weeks.
That'd be helpful. But one of the things I think we need to be really clear about, we're doing joint planning. We're not doing joint commissioning, because commissioning for me requires the money to be pooled. So for this year, we're going to be doing joint planning because we're developing a much better relationship around the things we do together. We need to carry on doing that. Yes. So, yeah. I just don't want to commit us to things, Rachel, that we're then not going to do.
I think it's fair to say, other than things like the Better Care Fund, which are obviously joint commissioning, this is joint planning.
Yeah.
So I think we ought to note that. And while you're here, Rachel, there's something about, again, what Margaret raised, being separated by a common language when it came to channel shift. I still think we have 1,000 different interpretations of the word prevention. At one end of the spectrum is prevention of smoking, long-term health and that kind of thing. At the other end is preventing people rocking up to A&E. And some of these things are preventative and prevention from that perspective. So maybe there needs to be just a little bit more clarity on the language when it's used.
So I think this speaks to secondary and tertiary prevention. So if you look in the planned care and cancer, I think what we're looking at really is around stopping diseases getting any worse, which is definitely secondary prevention. It's silent on primary prevention at this point, but I think that's the ICP partnership work where we should be really clear around primary prevention.
Well, I think it's a bit more messy than that, isn't it? Because, you know, smoking cessation in CFT, one of the important things around addressing inequalities is it's the NHS business to be part of that approach. So I would challenge that back to sort of say, oh, it's just sitting there. And I get your point about the ICP being the place, but it's a gap.
So I'm taking my lead from the Secretary of State for Health, and I know we'll continue to have a debate about this, and we are jointly responsible for primary prevention, but we're not responsible for mould in people's houses when it's a poor quality building, which across the country the NHS has got themselves into taking responsibility for that. Our job there is to lobby and to be very clear when our respiratory physicians are telling us that there are environmental factors that make in health work. We should be very clear about it. Within these commissioning intentions, it maybe feels like we're not being sufficiently ambitious, although we should note it is the most ambitious we've ever been, so within that context. These are about right-sizing the infrastructure for service access, which for our most poor and vulnerable people needs to be there whenever they need it, not whenever there's a gap that they can fit through. So I take your point, Rachel, and we'll try and rectify it somewhere in the narrative. But these, I think, are very ambitious commissioning intentions. They may not be ambitious enough, but we have to deliver them. So.
Okay, so we're going to go Nick, Tarn, Neil and Hugh. So Nick first.
Yeah, so Chair, I have both overall comment on the document and a technical observation. So do you want both together? Is that?
Please.
Yeah, okay. So technical observation with declaration of interest, knowing that I have connections to pharmacy. I think there's some stuff there about the primary care, reflecting the whole of primary care, things like point 21, review practice resilience. That should be primary care resilience, but I'm sure there's some technical things that could be picked up in there.
What page are you on?
You on? So that was page. The last point 21.
We're only dealing with page 15 at the moment.
My apologies. Okay, in that case, I'll be. Yeah, that's fine.
Pause.
I'll get you there before then. The other technical question is, I'm assuming we're core at noting we've had some people leave.
Yep.
Yeah. And then my overall comments on the document as a whole is absolutely this is the right thing to do. Having the privilege to, in other roles, be at things like Labour Party conferences and see Secretary of State speak and chairs of NHS England and all that kind of stuff. This is absolutely the right thing to do and the right thing to do. I think from INED or ordinary member point of view, I would come back to the reflections I sort of said with Susan before, which is around, I can see some names, but who, what, where, how. And from an assurance point of view, what I really want to have clear in is I don't want barriers when this comes back. If this is the right things to do, if people are finding problems, what are solutions? Yep. So when that comes back, I think, to the risk register and everything else that you've done. So my general observation, Chair, is absolutely the right thing to do. Can we be solution focused? This is absolutely about people on two fronts, the people we serve and the people that deliver the care. So let's not get institutionally hung up. Let's make sure that the right people are delivering care to the right people.
All right, and now
that's something I just want to capture somehow formally, please.
So Caroline, can you note that? And I think it just builds to the fact that we as a unitary board have just signed off a risk appetite that actually moves us up. So people should need to be into the glass half full, significantly ambitious mode. Tarn?
I'm going to say yes, and I think it's a start, as you say. But I think we need to look at the role that prevention plays in terms of looking at predictability on prevention, that this isn't actually about conditions. This is about socio-economic and equity of outcome in terms of who dies soonest. Not from a condition, but from a combination of different conditions, because they were in care, because they were born into that neighbourhood in poverty. And that's where we need to move in the future, is to look at how we measure that equity of outcome, not on a condition, but on that person's life circumstances. Because, as Rachel says, we need to look at the real deep prevention stuff, because we know that the best thing for changing that outcome is the person themselves and how we work with them to invest in their own health, not how we do to them to manage their condition.
And is that a general point, or is that aimed at?
It's specifically at that channel shift, because I believe that's where we need to go with channel shift, is to use our data to look not just more preventative for a condition, but more predictable in terms of.
Unfortunately, I think Rachel's intervention, which was helpful because she had to go, has broadened it beyond what I was hoping, a discussion on page 15, 16, 17. So can we just park prevention? I know we'll get to everybody. But Neil next, Hugh, and then Debbie.
So I've got one comment from Mary, because she had to leave, but asked me, she was talking about how we're going to measure whether interventions in the community like this are proving successful. I think we've talked about how we would look at things like this through quality and performance, but she wanted to raise that point. I'll pick up that one briefly. We talked about integrated neighbourhood teams before. The difficulty here is that we're talking high level. If we think about what people on the ground are doing, who are part of our health and care system, they are working in teams, and broadening those teams to include people who can make a difference to the wider determinants of health, can get local and personalised action happening. So that is a degree of prevention. It's advocacy as to, I can help you find the right person to solve these problems. The last thing is the end of life issue, Smitesh, is the way these things are framed. If I say to you that at the quality committee, when we took the end of life paper, it's almost as if by defining age 65 and over, if it had said people with multiple long-term conditions at end of life, it probably would have been less clumsy. But the point being made was what Kate said: we look after younger people with cancer really quite well. We don't do looking after a much bigger portion.
Thank you, Neil. Hugh?
Sorry. I don't, apologies, John. My point is a bit more broad as well than just those few pages. I think in general, we'd say that the GPs can support the intentions that you've kind of come up with, but equally coming into the idea that GPs kind of a broad church of GPs. At one end, I listened to the collaborative board GPs saying, yeah, we're good, we're strong, we're efficient, we're good with money, invest in us, we can take these ideas forward and make them work for you. At the other end, I see practices clinging on, sacking people because they can't afford their bottom line, or about to go hand their contracts back. So I think we can support it. We can do a lot. I mean, the COVID vaccination scheme is a good example of stuff that if you fund a GP right, probably through like LESs and things like locally enhanced services, we can be there to do a lot of this stuff if need be. We can find the resource, we can make the resource, and yeah, we support the intentions.
That's good to hear, Hugh. Thank you. Debbie?
Yeah, so broadly, I think the principles, there's a lot to like in the whole pack. Specifically to that one slide, which you're asking for comments on, urgent and emergency care. Can we please weave mental health into that? Because we do know that pressure is experienced in UHP and RCHT emergency departments, and we know that urgent and emergency care pressures are experienced in mental health with the ambulance, the police and so on. So I think that's an omission, and it should be clearer there. I also wonder whether we should be more explicit in this one slide about commissioning of capacity in the community for people with dementia, because we do know it's a real gap for us at the moment. If you look at our long lengths of stay, and I know dementia is woven into the narrative before, it's not explicit under urgent and emergency.
Good point, noted.
Care.
And Debbie, while you've got the floor, please turn the page to 16, and could you lead us on your thoughts on mental health and LDA?
Yeah. So again, I think I applaud this in terms of right areas. I think there's still a gap between the narrative intentions and this being a multi-year document, and on almost these slides then being year one. And I wonder whether we ought to be making that slightly clearer, because if I'm reading this as a multi-year document from a mental health, learning disabilities and autism perspective, I'd say we're not being ambitious enough. And I think there's more that we would want to do. You've heard from me earlier around the interface with primary care and the transformation of mental health care at the primary care level, and I would really welcome some consideration as to that being writ large in this. And I'm also really disappointed to see no reference to learning disabilities. And given when we're talking about health inequalities and population health and improving outcomes, we should be stating our ambitions to actually improve the quality of life and the life expectancy of people with not only a learning disability but severe and mental illness. And again, I know there's a slide later about children and young peoples, but again, children and young peoples also really feature in mental health and learning disabilities and autism, and I wonder whether we ought to be more explicit there. So those are my high level thoughts, John.
Very good. And I think just for the minutes, in terms of the exam question, I think we're answering on commissioning intentions in this document for 25-26. So there might be a 3-year medium-term financial plan on top of this, but this most specifically is a piece of work aimed at 25-26. Yeah.
But the narrative earlier says it's multi-year, and I forgot talking.
No. And I think that's why I'm asking with your help to actually say there's nothing wrong with having 2 to 3 years, but it needs to make it clear then which ones are. Yeah.
Is that we are taking our lead from the Joint Forward Plan, which is multi-year.
Yeah.
But we've got to be very clear that we can't boil the ocean. We've got to be really clear about what we can achieve, and what we've gone for in the commissioning stage are the areas that we know we are really struggling with. There are a whole other load of services that I know people will feel have been forgotten from here because they're not mentioned. That's not the case.
So don't worry, we can do a download now, refresh after a cup of tea and a slice of cake in a second, and then revisit some of this.
I would like to answer, if I could, before we move on, the question that Smitesh asked about, do we get an ED consultant into the community? So it's a really good question, because this is where we probably, this is where we start to protect our sovereign boundaries as organisations, and I understand why, and it's for very good reason. So that's where we have to be able to show the vision about what the benefits will do. So if we use that example, what we then need to do is with our CHT say, okay, so if that consultant moves, what workload would move with them in terms of avoidance of people going to ED? So that's the sort of the quid pro quo of redistribution resources. But we have to find a way of giving the confidence that's absolutely the right thing, because we can't afford to bring in new posts.
It's one of the things we hear.
It's one of the things that we do in the single point of access. No, I know, but it's a really good question, because that's where we get the most resistance.
So before I bring in Hugh, one of the things that I think I'm trying to play back to what I'm hearing is that on probably too many occasions we've got the right resources but in the wrong places, and there needs to be a commitment then, not just to sign up to the veneer of a strategy. When we actually get down to the level, which is why Nick's asking for the who, when, where. If we're genuinely saying we need those 5 resources to move from X to place Y, it's binary. Are they going to move or not? And if they're not, you best tell us now, because it's never going to work unless they do move. And that's what the level of granularity we need to unpack as a group, not just the veneer of the strategy, but do you get the implications, everyone, being institution agnostic, do you get the implications of redeployment, resource shift, channel shift? That's what we're trying to tease out. Bear with me, I've got loads of people. Neil was next. Yeah.
So it's just to say, no disrespect, but I think we talked about clinical leadership, and for me, there might be that I don't know who the right person to move from secondary care into primary care is. That's for clinical teams to work out for themselves. So I'd rather not at this stage be too prescriptive about a term like ED consultant. I'd rather,
as an example.
yeah, I know,
Yeah.
but I just want to make it clear,
I completely agree.
people might pick up on that with an expectation, and actually it may not be that for the people we need to look after, that is the right person. It might be a frailty consultant. It might be
Okay, so I'm going to bring in Hugh now, but I'm going to bring in Patrick and Kate as well. But Patrick, have a think about this, because by the time we get to the December meeting, what level of granularity are you expecting to have in your paper about whether it's a generic resource or whether it's these 12? I don't know the answer. Have a little think about that. Hugh.
I'm going to talk to the mental health ones this time. I think they're like really what we need to see. I think it's going to be much more difficult to achieve this though, because, and this may be an assumption, but my perception is there is more resource in a acute medical or acute physical health hospital. I'm not sure the resource is there within the mental health sector to be moving that out into the community service, unless you're just going to flatly stop all the spend on the out of area beds and just move that completely. But that is going to come with, you need the resource, the people. I'm not sure the people are there, so that's a really difficult one, but actually I would really support the intention. How you implement it, I think it's going to be difficult.
Okay, we'll come to that later, because let's not solutionise it now. We've got 8 weeks to do that, Hugh, so it feels like a lifetime. Let's go to Kate and then Patrick.
So I'm sitting here starting to feel very anxious, if I'm terribly honest, because I'll come back to the fact that these are ambitious. But they might not be received as ambitious, but they are. Darty tells us everything we need to know about where the money is, that over the last few years we have put more money into acute physical services than we have anywhere else. Mental health has grown a little bit, but that is mental health investment standard driven. And primary care has dealt with increasing numbers of people with a reducing amount of resource, no matter what primary care specialty you are. So these planning intentions are about shifting some of the resource from the place where we put too much money into a place where it's going to yield a better benefit for our people. And I don't think we are in a position to say whether it'll be 1, 3 or 15 consultants from ED. What we need to say is acute services, you will get no more resource than you have at the moment. You may need to deal with less. These are the things that we need to buy for our economy. So there will be the pre-commitments based upon our commissioning decisions for this year. We'll cost these out first, and then we'll have to have a discussion around pace of change across the places where people sit at the moment. And our trust may then decide to move people from one place to another or to transform a service. So I think we're having two different conversations around the same commissioning intentions. And these are strategically tactical. So they are addressing the things that will have the greatest impact for our people over the next year. We already have well articulated plans for mental health that sit codified in the mental health investment standard. These are things that we hadn't planned to do, we must do, or we will miss the point. And I've just spoken to Rachel, John, on the way out. If Rachel was in our team as the Director of Public Health, which remember in the olden days, in 2011, she would have been, I think she needs to set for all of us what the prevention commissioning intention should be. So, for example, should every NHS employed person or people employed on an NHS contract have two personal objectives around smoking cessation and hypertension management, that whoever they have a contact with, they deliver that as their, and they have to prove as part of their appraisal process that they have done something about it. ... They did that in Israel and it changed things really quickly. So I think there are things that we can do to augment these, and I'd like them to be read within that light, if that's okay.
Okay, so we're going to bring in Patrick.
I'll respond to your question in a sec. The point I wanted to make was stepping back, looking at the intentions overall. If I put myself in the shoes of a colleague working somewhere in our system, the presentation does a pretty good job of what and why. How will be my question if I'm in those shoes. What does this mean for me, and how my work's organised, and all of that.
So there's something that is a next 8-week piece, but we need to think about as a board is our change strategy for that, because we will reach that point where we will be talking with colleagues about implementing this. I say we in the royal sense. I mean, it will be
Be the royal family.
could be. It will be the employers of those people who will be subject to it. So, and the bit I wanted to highlight was how can we make that attractive as opposed to, because that's much more likely to engage people and make them want to do it, as well as what happens if we don't. And the narrative is critical for that, because that is saying, look, there are patient and outcome benefits here for a different way of working. We've really got to think that through. And in relation to your point about, so how detailed will we want to get to in the next 8 weeks? I'll answer it from the same perspective. If in January, February, we in the Royal Sense are standing up in front of people looking to implement this change, we need as much detail as possible in anticipation of their questions, and their questions will be really practical ones about well, what does that mean to my team? Who will I report to? How will work get allocated? How will a patient interact with us? All of those things we are really going to have to flush out in the 8-week piece of work to be able to. The test is the audience as much as the test is whether managerially we think that we're on the right track.
Very good, thank you. Nick, Sanj, and then we're going to wrap up.
Yeah, so thank you, John. I'm conscious I've already spoken. So just to sort of two things, really. One, to highlight what Kate says, again, having heard the Secretary of State speak, the one thing he did say was that the previous government had put more money in, but they hadn't reformed anything. This is about reform. That is the direction of travel. So everything that Kate's said, money linked to reform, is going to be really, really crucial. That's reform. That's different. That's important that it's different. The other thing is, one of my other hats, a reflection. I went to a respiratory clinical reference group, and we had a fantastic presentation from a pulmonary nursing team who said that actually, there was this problem, and I said, well, what about a super clinic like they do in diabetes at primary care network base? I'd love to do that. So what I think to Patrick's practical questions are, be brave. Let's make it easy. Let's be permissive. And up to my earlier point, Chair, solution, not problem. If the problem is this person works across two organisations, it's not difficult to sort out. This is fundamentally important with what we do, to look after the people that are delivering the care for the people that are receiving the care. And that's what we're here for.
Thank you. And having had a risk appetite that's significant. Sanj.
Yeah, no, I mean, I just wanted to note, I totally second Debbie's point on mental health and that provision being woefully behind. We had that presentation at the last ICB, but also just listening to comments from Smitesh and Hugh, whether we are really fully bottoming out primary care comments into the next version. We need to, and hopefully that will be the case, because they're going to be the receivers of this plan in terms of some of the delivery. The big question for me is shifted from money to, I think, staffing and, can we hire, move, or whatever it is to be able to do this? Because, the data around the staffing levels for 2050 that Patrick shared, it's already a problem now, and it comes through in some of the comments we've heard as to whether we've got the staffing for our ambition. I don't think money or that is the primary issue now. And lastly, I think it's just measurement against diagnostics. So certainly from a F&P perspective, we're looking at, is this going to shift the diagnostics weight? Is this going to shift mental health? Is it going to shift ambulance halls, etc.? There's a few metrics where, however much we do things and build places, is it going to shift that? Because I think it ultimately ends on the comms trail, where hopefully, Lucy, when we do comms stories, has won every ICB around something we've done as a result of this channel shift, and we're explaining it in every sense. But also can say in a radio interview, as a result of this channel shift, we've improved ABCD of care. And the last part around comms, this is essential, is we keep getting the problem that clinical pathways keep leading us back to Trelisk and not using SDEX and other things. So we've got to have a comms drive with this to push people away. Otherwise, we'll create it and build it, but no one will come because they still think Trelisk is the safe haven. So comms was my last comment. Thank you.
Thank you. I'm going to be a bit mean, Claire and Rich, just for a moment. We have a significant amount of time later. I'm going to ask you just to pause your thoughts, because I want to just finish off, as it's now nearly 1:30. We're half an hour late. I'm hoping that your concern is abated a bit. I think this is an excellent start to a discussion piece that will continue during the day and be over the next few weeks, and particularly to the next board meeting. I'm not parking primary care and the others. I'm just going to revisit them later, if that's okay. Is that all right, Smitesh, from your perspective?
Absolutely.
Thank you.
Thank you.
So I think what I'm going to say for the minutes here is we've had a robust conversation, and it's been a great start. Lots of input. And the work now needs to lead to some granularity for the November board meeting. You happy with that? Lovely. Thank you much.
Could I just add, John, I think the principles were warmly received.
Oh, yeah. We should note that.
So I think we should note that.
Yeah.
I don't think there's any disagreement about the principles or the approach or the need for ambition.
Yeah. No, okay, I'm going to take up 30 seconds more. Because it's in my chair's report. Nationally, acutes have had funding since COVID, and nationally, acutes are not as productive as they were pre-COVID. And the number is very chunky nationally, and it's £36 million in Trelisk alone after pay rises and transfers in. We know the model needs to move on. We know that UHP, which we'll find out later on, have got some answers to this. What we've got to do is to say, if we want to do these things, what do they look like, and what resource shifts, money shifts, and or both or different? I don't mind what they are. Just be clarity, because I don't want any partner getting to December and going, oh, I bought the principle, but now you're mentioning X. No way am I going there. We need to be frank with each other and say, if we want to do X with enough detail, it means Y implication. Are you up for it? Because if not, we cannot get to a consensus in December, if that's all right with you.
Yeah, I think I was supporting the document.
Yeah, no,
I wasn't challenging it.
No, I know you weren't. I was just endorsing what you were endorsing. Okay.
Thank you, John.
Thank you. So let's move on. Now, Kate, I'm going to ask you on the sustainability climate resilience bit. It is for information.
Would you receive it?
Yeah, but there's a lot of recommendations in here. So I'm not so sure we can, as it's an input for information paper, quite take the recommendations. So can I do it this way? Can I ask the board to note, having now read, because I know in the report that we had when we did a self-assessment last year, you all said to me through that survey, we never talk about climate resilience and sustainability, etc. Well, here is the report. It was talked about a lot at the committee that I attended. I was the one that asked for it to be for information here, but it comes with a lot of recommendations. Would it be fair to take the recommendations next time and have this more, or how do you want to deal with this?
So should I take the recommendations into my chief exec's report next time? And
Why don't you do that?
And then we'll just ask the board to confirm.
Because this is really just for you to read and see that's gone into committees and that kind of thing. Thank you very much. So on that basis, forward agenda, it feels like looking at here for November, we've got the elective plan, the operating plan, except what we're now talking about is an operating commissioning intentions plan, really, that's going to have commissioning intentions, it's going to have finance, it's going to have a workforce plan, and by somehow, hook or crook, it's going to have a digital something or other, either a separate paper or woven in. Okay, are you happy with that?
Yeah, very happy.
Caroline, have you captured that? And then on top of that, there's going to be the elective plan, Director of Public Health report. I don't know if that's needed, but let's have a conversation. Do we need safeguarding next month? Susan?
The annual report needs to come.
I think it's the annual report, yes.
Okay, so the answer is
I will
yes.
double check though.
Yeah. I don't think I want us to create as much time in November and December for the discussions on commissioning intentions. So would it be unreasonable to park research and innovation?
Again, it's a statutory duty. You just need to find out when we need to report our statutory compliance.
Just check the
It
time.
goes through QPOC, so can't we just have a note from the chair that says QPOC considered and here's the answer? Could we do that? Lovely, thank you. Federated data platform, why don't you put that as part of your wider commissioning intentions document? But we do need because if Rachel was here, she would be whispering in my ear now. Transforming primary care strategy and the recovering primary care NHS requirement, 2 documents. So can I assume that as it's all aligning towards the commissioning intentions, that although there'll be separate papers, all roads will be leading to...
Yeah, they're strands of our commissioning intentions for our plan in 25-26. Very happy.
Lovely. Everybody happy with that? If there's anything else that come out, Kate and I'll chat it through. So that's the forward agenda. Item 17, is there anything from the public who's here that's actually relating to the agenda? I'll just pause in case the hand needs to go up on the screen. No? In which case, I'm going to formally, Caroline, close the meeting. And could I ask us to be back? Is everyone all right to be back at 2 o'clock?
Yeah, perfect.
Yeah, 2 o'clock. Thank you very much, everyone. Let's shut down the meeting now. Thank you.
Thank you.